Hello everyone, I am Rizita Galimova, a neurosurgeon and CEO of Intelligent Neurosurgery Clinic. I can hardly explain the excitement and feelings I have been having today due to several facts. First, a year ago on this day, we performed the first in Russia MRI-guided focused ultrasound treatment. And today, we welcome all of you to our first focused ultrasound non-invasive neurosurgical congress. Our robust program was built according to the most important questions in the field of focused ultrasound in neurosurgery. Our speakers are pioneers and enthusiasts putting all their effort to change the way of delivery of medical care by using this amazing technology. This event is online, but we do understand that face-to-face collaboration and social meeting cannot be replaced by digital technologies. And we do hope that the next meeting on our Congress, we will do it not online and we'll shake your hands and see each other not online. We are here today together because we share the common vision and we want to change the way of medical care today and help patients with different medical problems with using this technology. I would like to thank you, all of you, for participating today and being the part of the Congress. I am very grateful to all our speakers for sharing their knowledge and making the world go round. I'm very grateful to our team members working so hard during the whole year and trying to be the best medical center in Russia. It's not possible to imagine the work in the innovative field without strong research support. And our collaborative work with Bashkir State Medical University is very successful. Let me pass welcome message to the Mr. Pavlov, Rector of Bashkir Medical University, academic, and the person who changes the way of how medicine is taught in medical universities. He will definitely inspire you to become better.
On behalf of Bashkir State Medical University, I am glad to welcome you to the online focused Ultrasound Non-invasive Neurosurgery Congress. Our university is a famous cutting-edge center of medical and pharmaceutical science in the Russian Federation. For about 90 years, our institution has been successfully training specialists for healthcare, scientific and pedagogical work in the sphere of professional medical and pharmaceutical education of the Russian Federation. Scientists of Bashkir State Medical University successfully represent our republic and Russia on the international events in different fields of natural science. More than 11,000 students are studying in Bashkir State Medical University, including more than 2,500 international students. Bashkir State Medical University is famous for its School of Surgeons, Neurosurgery, Oncologists, Cardiologists, Morphologists, all around Russian and world medical institution. Today we are at the center of Russian and international medical events. To this moment, Bashkir State Medical University's list of foreign partners included about 50 universities, clinics, scientific and educational centers of Germany, China, USA, Norway, Austria, etc. Nowadays, our students, physicians, and professors are being integrated in international practice. Our scientists and are conducting joint research on topical problems of medicine. We are proud our conference on cutting-edge technology was organized by our professor, and we welcome you for opportunities for international cooperation in education, science, and innovative work.
Focused ultrasound technology would not be possible without hard work from Inside Tech company. These guys do great job connecting chemistry, physics, medicine together to change the way of medical care and put medicine in the humanity way. Let me introduce the Vice President of International, Ronnie Yaigel. He has several very interesting words to all our participants. Please welcome Vice President of Inside Tech Company, Ronnie Yaigel.
Dear participant, on behalf of the family of InsiTech, I wish to welcome you to the Focused Ultrasound Non-invasive Neurosurgery Congress. We are honored to join, even in a virtual way. And we are proud of our first active treatment center in Russia. The team here has done a remarkable job of treating more than 30 patients and is now fully trained and certified, joining more than 100 treatment centers established across more than 20 countries around the globe. What took other technology decades has been achieved by our technology in less than 5 years. We have treated thousands of tremor and Parkinson patients with record safety and efficacy results. Our centers around the world are busy expanding the use of this technology in many other directions. And we are looking forward to hear more from the distinguished speakers that gathered here today. We wish you success and hope we will meet again face to face sometime soon. All the
Thank you, Ronnie. And let me pass the welcome message to Professor Shamil Safin. He was the first person who supported us from the bottom of his heart, helping us with all difficult questions and doing his best to help us to do the first operation together. Professor Shamil Safin is the head of our neurosurgery department, and he's the chief neurosurgeon of our region. Please welcome Professor Shamil Safin.
Distinguished speakers, colleagues, ladies and gentlemen, a very good afternoon to everyone, and thank you for joining us at the first annual Focused Ultrasound Non-invasive Neurosurgery Congress. As the Higher Neurosurgery Supervisor of Healthcare Ministry of Republic Bashkortostan, I would like to present my compliments to all academic colleagues and administrative authorities participating in this conference and express to you my deep satisfaction for sharing this important moment for the development of non-invasive neurosurgery. To our eminent speakers and all participants who have connected from Spain, Japan, Taiwan, United Kingdom, Israel, United States, Russia, and all world, I am greatly honored and pleased to welcome you. We are indeed honored to have you here with us. Focused ultrasound neurosurgery in Russia started here in Ufa in collaboration of International Medical Center, Buzaev Memorial, Bashkir State Medical University, and Ministry of Healthcare of Bashkortostan Republic. And today is 1 year anniversary from the first case done in Russia. I hope this Congress will become the good tradition, friendship, and international collaboration in frontiers of non-invasive medicine and neurosurgery. Thank you very much. Good luck.
Thank you, Professor Shamil Safin, and we are moving forward. And I'm so excited to present one of our participants. I think everybody has been waiting and with real excitement to see and meet with Professor Takaomi Taira, even online. He's the pioneer and he's the person who inspires many, many people globally. Even our small medical center, every day we read his articles, we look at him, we follow his team, and we want to be like him, maybe better, I don't know. Let me introduce Professor Takaomi Taira with his presentation. Today he will explain more about dystonia, patients with dystonia, and how can focused ultrasound treatment help these patients who without any help. Please, Professor Taira, thank you for participating in our conference and thank you very much for accepting the invitation.
Thank you very much, Dr. Guy Mobra, for a nice introduction. And it is my great pleasure and honor to attend this exciting conference. So we started the focused ultrasound treatment in year 2013. So we have already 8-year experience. And Parkinson's disease and essential tremors are already established and reimbursed from the government in Japan. And we are now targeting the next indication, which is dystonia. And talking about dystonia, most neurosurgeons say, okay, GPI, globus pallidus, internal deep brain stimulation is the best indication, best choice. And I have been doing the GPI deep brain stimulation for more than 20 years now. And one day I now, okay, just a moment, I share the screen, share sound, optimize video clip, this one. Just a moment. Can you see the video or screen?
Yes, we see your screen, Professor Taira.
Okay, okay. And so today, I'd like to talk on the possibility of ultrasound treatment for dystonias. And over the past 20 years, I have done, I think, several hundred deep brain stimulation operations for patients with the dystonia. And one day I encountered such kind of patient. This is a young man with actual dystonia and who had the severe laserocolic posture. And he was treated with deep brain stimulation, which worked very nicely like this. However, the device became infected and we had to remove everything. But when we stopped the stimulation, he had very severe dystonic status. So we had to make a lesion through the DBS electrode. Here you can see the DBS electrodes, and here you can see bilateral pallidotomy through the electrode. And he became like this. And this was, I think, 10 years after bilateral palidotomy. Okay, and he is working as a banker, and he's completely free from the device. So we started using GPI palidotomy, not for DBS, considering the disadvantages of device implantation. And if you look at this lady, she has a jerky neck movements. And also she has bending of the body when she tries to walk. We call this camptochomia, like this, difficulty of walking and the body bending. But even unilateral palidotomy controlled such kind of symptoms. And she can walk smoothly like this. So palidotomy is still very, very useful. And if you look at this gentleman, he has orofacial severe dystonia treated with bilateral staged palidotomy. And he became like this. He's completely normal and returned to the normal life without any deep brain stimulation or devices. So, however, after experience in many patients, we have seen some patients who had secondary Parkinson's disease symptoms after bilateral GPI palidotomy, and which is, I call it postural instability and gait disorders, PIGD. And it was seen only in bilateral cases, and which is refractory to L-DOPA. And such kind of cases were seen in 25% of patients who had bilateral GPI palidotomy. So we considered to make not bilateral symmetrical lesion, but the asymmetric target like this. Here, GPI is here. And if contralateral lesion is necessary, we target PTT, which is palidothalamic tract. Here you can see in functional neurosurgery, we usually target GPI or subthalamic nucleus here. And here is there are two tracts from GPI to the thalamus, and which is one is under lenticularis, another is lenticular fasciculus, and which unite together here like this. This point is on the corner section of the map here. You can see the subthalamic nucleus. Lenticular fasciculus is blue, red is under lenticularis, and the palidothalamic tract target is here, which is lateral to the mammillothalamic tract and above the subthalamic nucleus. And this target has several advantages. For example, in case of a focused ultrasound, the lesion or target should be more centrally located to obtain good temperature rise. And the target, PTT target, is 8 to 10 millimeter from the midline. So it's easier to raise target temperature with focused ultrasound, and the volume is very small. And this structure is far from an internal capsule or optic tract. Here you can see the optic tract. GPI is around here. And here you can see the subthalamic nucleus, and the region of pallidothalamic tract or foveal edge is here. In the axial section, you can see the mammillary tract, and it's 3 to 4 millimeters away from the mammillary tract. And nowadays we can visualize the target with the special computer program, and the space between the subthalamic nucleus and the ventral-oral thalamus. Here's the zona inserter, and the exact target is here. We call it pallidothalamic tract or foveal edge area. And we have already published the data of PTT Tommy for dystonias. This is a unilateral study, and dystonia rating scale improved 74%, as you can see here, and the long-term result was not very bad. And so nowadays we combine multiple GPI plus PTT or ventral-oral nucleus bilateral GPI, same, or bilateral thalamus. By combining such multiple targets, we treat the very complex symptoms of the patients. For example, this young man had such kind of axial dystonia. He initially underwent the right GPI, Tommy, radio frequency, and we did contralateral PTT lesioning. And this is after the operation, total operation, and he's completely symptoms-free. No mental or emotional side effects was noted. And for example, this young man had such kind of pineal region tumor. After treatment of chemotherapy, it stopped, but he had such kind of, he started having such kind of abnormal movements. And like this. So initially we did unilateral PTT, GPI, and this is after unilateral GPI Tommy, and we added contralateral PTT here, and this is the final results you can see here. So we haven't seen Parkinson syndrome after combination of GPI and the PTT lesioning. And if you look at young boy, this is a so-called secondary metabolic disorder, a metabolic disorder of the iron. We call it a PCAN. And he has very severe generalized dystonia, and he was treated with unilateral PTT, pallidothalamic tractotomy, under general anesthesia, and this is 1.5 years later, and he can walk, and it was a dramatic change, even in case of secondary dystonia. And if you look at this lady, this is a lady with Huntington chorea, and she had the very severe dystonia or dyskinesia or such kind of very severe movement disorders. And when she lies down, the legs are moving like this. And we did unilateral PTT, pallidothalamic tractotomy, and this is 6 months after left PTT lesioning. And surprisingly, it has bilateral effect. And in case of unilateral PTT lesioning, some patients show bilateral effect, as you see here. And so also we have started using radio frequency or focused ultrasound pylorothalamic tractotomy for Parkinson's disease. This is a typical example of frozen gate in Parkinson's disease. And this is one day post-op, one day unilateral PTT. And she had the severe dyskinesia in on stage, and which completely disappeared after surgery. And she had on and off, she had the peak dose dyskinesia like this, but this is post-op, and her symptoms is very much stabilized. And so we studied already the unilateral pylorothalamic tractotomy for akinetic rigid Parkinson's disease, and the UPDRS changes. You can see here is a good improvement after 1 year, and we didn't see any severe adverse events, but some patients had the hypophonia or decreased response to levodopa. And among our experience of pylorothalamic tractotomy, 2 patients had the intractable epilepsy, and they had 1 to 3 epileptic attacks in a month before control of movement disorders, and they underwent PTT, pylorothalamic tractotomy, for arm dyskinesia or arm myoclonus. And surprisingly, after surgery, such kind of epileptic attacks disappeared, and the over decreased very, very much. And probably most neurosurgeons do not know that in many years in 4H area or pylorothalamic tract area was considered as a treatment target for intractable epilepsy. For example, here in 1960s, Dr. Jinnai reported that the many patients after 4H-tomy for intractable epilepsy, in many patients, the symptoms or epileptic attacks was abolished in many cases. So I think the 4H or PTT can become a target for intractable epilepsy too. And it is also interesting that recently the Clements and Neudorfer reported in 2 patients that the Tourette syndrome was controlled well. For example, if you look at the Y-box score, it was dramatic improvement here. And Tourette syndrome improved like this with deep brain stimulation of forward field H. And another 4H field is here, as I said, fascicular lenticularis and ansa lenticularis, subthalamic nucleus is here, and both projects to the ventral-oral nucleus of the thalamus. And many neurosurgeons have already known that we have been treating focal hand dystonia by using ventral-oral nucleus target. And I don't know why, but in case of axial or orofacial dystonia, the GPI or PTT is very effective, while in case of finger and hand dystonia, ventral-oral nucleus lesioning is more effective. I don't know the reasons, but this is our experience. And we have published already the many patients report, 171 patients, and the effect is very sustained for 4.3 years for a period without any severe adverse events. And so this is an example of the typical example of the focal hand dystonia in violinist, and he cannot use the little finger or fourth finger like this. It is automatically bent. So during surgery, we do like this, and this is this is after the operation. Here, he can use all the fingers like this. Okay. So effect is dramatic. This is a drama, the left focal hand dystonia, and this is after operation. So also some patients may have foot dystonia. This is a typical example of left foot dystonia. When he goes up the stairs, it is normal. But when he goes down, his foot is inverted like this. And after unilateral ventral-oral thalamotomy, the inversion was completely normalized. And also, of course, we can do such kind of treatment with using gamma knife. For example, this is an old lady. She was not suitable for surgery because of her cardiac problems. So and before operation, before treatment, she was not able to use the right thumb here because the first finger became bent like this. Okay. But after gamma knife treatment, after 1 year, she became like this. Now she can use all the fingers, as you can see here. So it was very natural for us to use the focus ultrasound for such kind of focal hand dystonia. We made MRI compatible guitar, and we started the study in 2017, and we have already finished the 10-case study. This is an example before treatment, and little finger is bent during play, and this is after the treatment. Here he can't use the thumb. There, see, because thumb is extended. Here he can use the thumb, and this is an example of pianist treated with focused ultrasound. And okay, so we experienced or we investigated 10 patients with focal hand dystonia some are writers cramp, some are musicians, some are artists. And at day one, you can see here the edema targeting the ventral oral nucleus. But after 1 year, it became almost invisible. And the writer's cramp rating scale was very much improved. And the musician's dystonia scale, 1 means cannot play at all. So the musicians are very bad in performance, but 5 means complete play, so which is very effective. And of course, it works. Writer's cramp. This patient cannot write almost at all. And 6 months after focused ultrasound treatment, his writing is very smooth now. This was a result of focused ultrasound ventral oral thermotomy. And of course, we started the ultrasound pallidothalamic tractotomy for Parkinson's disease. And this was, so far we have treated 7 patients. And our study protocol is for 10 patients to study. But this was the first patient. She was very akinetic, almost cannot move at all. We asked her to stand up, but she can't. And this is 1 day post of medication. And now it was a dramatic change. And the target is here, subthalamic nucleus, ventral oral thymus is here. So in conclusion, already in Japan, the unilateral VIM for essential tremor and the unilateral, GPI or THAMS for Parkinson's disease is approved and reimbursed. And every week, many patients undergo such kind of treatments. And we are now targeting to make reimbursed for ventral oral thermotomy for focal hand dystonia. And also we just, the Parkinson's disease study is ongoing. And Dr. Chang will talk about the XDP, X-linked dystonia Parkinson complex. We are doing the international cooperative study now. And we are preparing the PTT for cervical dystonia and the epilepsy. So thank you very much for your attention. This is, I thank all the members of our staff. Thank you very much for listening.
Dear Professor Taira, thank you very much for your presentation. We do really think that your team and you inspires many doctors, and I'm very happy to see colleagues from different parts of the world connecting to our Congress. And I think we have a lot of questions. Many of them told us that they will be very happy to see you on the discussion meeting. So we are going to have discussion meeting at 2:40 Moscow time. So, and many of them, they just dream to meet you online and ask you questions, and hope you will connect to the Congress again, and we will be able to ask questions to you.
Okay, thank you very much.
Thank you, Professor Taira.
Thank you.
So let me share our experience, working experience during our first year. You know that it's quite difficult to be the first medical center providing MR-guided focused ultrasound treatment to the patients, and you know that we are the only one in Russia. The difficult part is that the level of awareness among patients and doctors are quite low, and even many medical specialists have been thinking that this technology is still like experience or being research. We started a year ago on 5th of May. The plan was quite simple. We decided to launch the technology in the end of March, but things changed dramatically for everybody on the earth with the COVID-19 pandemic. Everything was closed, airplanes, airports, roads, everything. So we were closed too, and inside tech company specialists were not able to come to our medical center and help to start the technology. We were so afraid, closed, and disappointed. No one had any information about how long it should be and what the end is going to be. As very active medical center, we sent the letter to Ronnie Yager, vice president of Inside Tech company. You have met him before, asking the permission just to give us very basic training to know more about the technology. Ronnie allowed himself to pause for 2 weeks, and he returned with the answer yes in 2 weeks. So we started our training. All materials were sent to our clinic, and here you can see funny photos from our first daily quality assessment, and you can see our faces, and it seemed to us as difficult as the rocket science. We performed several treatments on phantoms, and no one was damaged, and every phantom survived. And after dozens of treatments, we sent the second letter to Inside Tech company asking to allow us the remote treatment. Inside Tech company this time set 1 week to pause and discuss with lawyers about the possibility. They returned in 7 days with answer yes, and we started to prepare for our first operation. Before that, our MRI rooms changed dramatically. You can see here a lot of computers, a lot of digital programs. Everything had been changed to help us to work with Inside Tech applicants Paul Rek, Tessa Case, and Daniel Molchanov. Later, Professor Buzaev will explain step by step everything that we've done as the preparation level. So far, on 5th of May, we've treated our first patient, 86-year-old male with tremor-dominant form of Parkinson's disease. It was the longest treatment, more than 200 minutes. Everything was new, everything was unclear, but we were successful. And here you can see our patient in 12 months after treatment. He's doing very well. Before the treatment, he had right hand tremor, rest tremor, and postural tremor. And now he's all right. He lives the life he dreamed to live during last 4 years. So my message today is that we are not only just the first medical site in Russia using MR-guided focused ultrasound, but at the same time, we are the first medical center who started very difficult neurosurgical technology remotely by digital support from Inside Tech company. After us, the same way, many centers followed our way, and they did the same. and we are very happy to be the first people who were able to do these things. During the first year, we had problems with pandemic and COVID-19, of course, that cut the number of our patients. You can see here that we were able to treat 35 patients with tremor-dominant Parkinson and essential tremor. And you can see the geography of our patients. They're mostly from our region, but we have 2 patients from Kazakhstan, Ukraine, Latvia, and Romania. Here you can see the stages of the operation. They're same as for every MRI guided focused ultrasound center. We do the same things. We check patients before, then we fix the neurosurgical frame, put the membrane, and do everything step by step to verify, treat low, and then treat high. So the longest operation was more than 200 minutes. The shortest operation was 58 minutes. We have a team of 3 neurologists, 2 MRI specialists, and we do all operation on the same day. We do MRI control after 2 hours of the operation and allow patients go home in the evening after control consultation of our neurologists. Here we can show you the patients we try to work on the patients and help them in, can you start my video, please? Here you can see patients, and this patient demonstrates our ability to help patients with tremor and hand tremor, leg tremor, head tremor, and mandibular tremor. Can you just start the second video showing the results of the treatment? This 68-year-old lady had been having Parkinson's disease for more than 10 years. She decided not to go with deep brain stimulation, and she came to our medical center, and before the treatment she had severe tremor, disabling tremor from her right side, you can see, and at the same time she had tremor on her head tremor and mandibular, and moving through the VIM nucleus we were able to help her with her mandibular tremor at the same time. You can see that after the treatment she can just write, she just can drink, do just all routine things without any support, and she was totally happy. Now we are following her more than 3 months and she is okay, and this is her mandibular tremor, and she's quite happy as we are too. This is one of our patients. Please start video for me. And he came from Ukraine. He's right-handed, but he preferred to be operated from his left side. And you can see his, on next video, you can see his left hand after 6 months after the operation. I'm showing this case because we are planning him to do bilateral in October this year, and he's ready to be treated bilaterally, and we are ready to help him to return to his profession. He's a young businessman, and help him be as successful as he dreams to be. This is our oldest patient. He's captain, he's left-handed, and he had written, and he's a poet. He had published his first poems and presented to us, but 3 years ago his left hand started to shake and he was not able to write anything. He stopped to write his poems, and he came to us. And telling the truth, his older son, he's a neurosurgeon, and it was so fantastic to treat your colleague's father, to help him to return to his normal life. And now he has started to write by his left hand, and I hope to see his poetry book in next year again. This is the statistical data of our Parkinson's disease patients. You can see that we had 25 patients, but we operated 27 times because one of our patients had tremor reoccurrence and we did him, and the other person had elevation of arterial pressure and we stopped the operation and then we did it again. So the duration of treatment is around 2 hours, and you can see that mostly we can change and work with UPDRS 3 part 3. Essential tremor patients, unfortunately, we had them less than Parkinson's disease patients, 10 patients with essential tremor, and you can see that we have dramatic change. Most of our patients with essential tremor are bilateral. That's why on marine rating scale, we can see that 50% improvement according to this scale due to the bilateral of essential tremor. Coming back to my first slide showing that we are the first center started in COVID era, and I'd like to share with you what we have done during our first year just to explore and increase the awareness about the technology and do more and help the technology to be known with more patients, more doctors in Russia. So in our region, we have something like surgical Oscar. It's called the golden scalpel. Usually the most innovative technology operation is granted every year. And last year, our medical center and the technology was granted with the golden scalpel. And here you can see Professor Safin, me, and Professor Buzaev with this very, very high Oscar-like nomination for our region. And we did very interesting film. It's called The Spiral. Here you can see the link to the film. It was done 7 months ago and it have more than 3,000 views by people from different parts of the world. This very short movie, very touchy movie about the dream of a very 8-year-old girl to help his father with Parkinson's disease. And through this film, we tried to show that everything is possible. Even a little girl can change the way how her father lives and how other people can come and be the part of our team, be the part of this technology. And it was very interesting working on this film, being the movie actress and working with the professionals doing this marketing thing. And our last activity on 11th of April, with the help of Inside Tech company and with the UFA Marathon, we launched the first Parkinson Day Run in our city. We were able to gather and money and financial support to one of our patients with Parkinson's disease and help him to be operated in the next month in our medical center. More than 300 people participated in our first marathon on Parkinson Day. Several cities like Moscow, Chelyabinsk, Orenburg, Kazan, it was online, digital, and everybody who registered was able to run and support this day. It was really great, and we hope so that this marathon will become annual event and we will help more patients. And you can see on one of the photos that our patient ran too with other participants. I'd like to thank all our team for great work during this year. I understand that it's quite difficult to be the first. It's quite difficult to do the first steps, to be a little bit disappointed, a little bit afraid, but with the great support from Inside Tech company, with the great desire to achieve, with a great desire to be the best medical center in Russia, I think we can do a lot of, with the support of our colleagues like Professor Tyra, like Professor Chang, like Professor Nandi, and like Dr. Karante. So let me pass my words to Professor Chang, who is patiently waiting for presenting his speech. Professor Wei Chen Chang, he's a neurosurgeon. He's the chief of Emerging Fast Treatment Center of Changbin Shuan Memorial Hospital, Taiwan. He's one of the pioneers, inspiring us and inspiring many doctors from different parts of the world. Please, Professor Chang, welcome.
Yes, thank you, Professor Kalimova and Professor Ignov for the organization and the invitation. And I think in Taiwan, we have 3 centers have this kind of facility. So we start this treatment from 2017. And also we thanks Professor Tara to guiding us and helping us in this treatment. I think my speech is pre-recorded, so please. Is Zhang Weijie from Sichuan Memorial Hospital, Taiwan. It's my great pleasure to share in you our experience in the treatment of this kind of non-incision surgery. This is my disclosure. Most of our clinical trial was sponsored by my boss. He's President Minghe Huang from Sichuan Healthcare System. Today, I would like to first show our case summary and also share you some patients we treat and interesting cases. And in the end, I would like to share you our experience. We set up this treatment center from 2017 till now. We screened about more than 600 patients. As you know, most of the patients with movement disorders are essential tremor, followed by the Parkinson's disease. So there are more than 400 patients with essential tremor. So from 2017, we already treated about 90 patients. There were 68 patients with essential tremor and 16 with Parkinson's disease. For those patients with Parkinson's disease, we treated include tremor-dominant Parkinson's disease and Parkinson's disease like rigidity and slowness. Also, we have a very special case diagnosed with X-linked dystonia Parkinsonis under our IRB surveillance. We have 4 cases. This patient is mainly from Philippines, and later I will introduce this. Also, since last year, we have a new clinical trial. We treat 2 patients with dystonia. We select a patient with orofacial segmental dystonia. So till now, we have 6 clinical trials and 3 global multi-center. 2 of them will stop the enrollment. And this year, we will soon start a new clinical trial. It's staged bilateral parietal thyroidectomy. For our protocol to the treatment of essential tremor and tremor-dominant Parkinson's disease, we enrolled the patient with whose scar density ratio equal and higher to 0.35. In Taiwan, in our study, the scar density were not as high as those patients in the West. Later, I will show it. And the target setting is like this. We select the target from posterior commissure. It's about 1/3 ACPC length and minus 1.5. And from the wall of thalamus, it's around 11 to 12 millimeter. And we select the target 1.5 above the ACPC plane. This parameter, we mainly got the idea from Professor Tyra. And later I will show some interesting cases for this. For MR-guided focused ultrasound, I think everywhere in the world we select an indirect target, then adjust the real target according to the feedback from the patient. First is we can see the tumor suppression and the sensory response. We can make a fine adjustment of the target. This is the distribution of scar density ratio we studied in Taiwan. So there are about 1/3 of the patient whose scar density ratio is lower than 0.35, which means it is very hard, even it is impossible to make a real lesion. So there are 1/3 patients who will not suit for this technique. And also a patient, the scar density ratio higher than 0.4, they are only about half. So in Taiwan, it's a little bit harder to select the patient with a good SDR. In our center, the eldest patient we treat is 90 years old. So you can see from this 90 years old patient, you can see we treat his right hand. You can see before and after, it looks fine, even though there are little fine treatment could be seen. But for elder patients, most of them have heart problem. They may have a lung issue. So for traditional craniotomy and the general anesthesia is very dangerous for them. So this non-incision surgery provides a very good choice for those patients with old age and some heart lung problems. So this case we treated is 2018. About a month ago, he visited us. He would like to try to have another site of surgery. So this year we started bilateral thyroidotomy for patients with essential tremor. So after first treatment, around 1 year, it looks now it looks now very safe, and the morbidity and adverse effect were not that high as radio frequency did. And because our center set up very early, so this is the tumor dominant Parkinson disease. We have the first treatment in Taiwan. For Parkinson disease, it's interesting, a little bit different, like patient with essential tremor. You can see from the patient on the table, you can see the tremor gradually stopped because the tremor is resting tremor. So when patients have a tremor, you know that you are not on the target. But if you are on the target with the increasing the temperature, the tumor stopped. So it's very easy to observe the patient with tumor dominant Parkinson. You can see from pre-op and post-op, the tumor stopped. This is a 60-year-old patient. He initially diagnosed with essential tremor for about 25 years, but in recent 5 years, he get Parkinson's disease. So in our series, there are about 5 to 7% patients initially presented with essential tremor, and Parkinson's disease will combine. So it's about 7%. For this patient, you can see the resting tremor, intention posture, very typical sign. You can see from pre-op and post-op, it looks very nice control. But after, this is the post-op, the lesion, the location looks good. But after 3 months, you can see the tremor a little bit coming back. You can see when he holds the spoon, you can see a very fine tremor were observed. So for this patient, he would like to have a better control. So he coming back for a second operation. You can see before and after. But in this case, the time from first and the second operation, it's about 3 months. So after second operation, you can see that the edema and the internal capsule would have the zone 2 area into the internal capsule. So patient have a little bit gait problem and numbness over his tongue. So in our experience, we suggest that if you would like to have a second operation, you should take maybe longer than 6 to 12 months. It might be better. And also, for patients with Parkinson's disease, we have a feeling that you might have a larger lesion to get a better control. And especially for those with ETPD, it's have more complicated. If you control the ET part, the PD part might still there, because Parkinson's disease is a progressive disease. So medication should be prescribed in those patients with Parkinson's disease. Also, we might have another target to get a better control. This is a very painful case from our site. This 62-year-old female is our 31st or 32nd patient. At that time, we feel very confident in this technique, and we are very proud of that we are an efficient team. Usually, we from the frame on to frame off, usually it takes like 60 minutes within 1 hour. But we met this, after this painful case, we adjust our policy. For this case, because at that time we have more confidence in this technique, so we search some papers, and in the West, they usually choose the target at the ACPC plane. So for this patient, she had a good scar density ratio. It's a 0.61, and during the whole operation, the patient looks fine, and we totally use 6 sonication to reach the temperature, and the last 1 or 2 sonication, the temperature reaches to 60 degrees. At that time, the patient complained about headache and some numbness over her tongue, but for the movement, it looks fine. So just after the operation, take off the frame, we can see the lesion. It's a little bit invade into the corticospinal tract, like the coronal view show, and a little bit involved in the subthalamic nucleus. In our center, we send the patient with wheelchairs because after the operation, they take the wheelchair back to their ward. So at just after operation, we did not notice about the gait problem, but the patient complained about 6 or 5 hours later, she got severe dysmetria. So after 1 day, we can see that the patient, the post-op day 1, we can see the edema and the zone 2 area invade into the internal capsule, even push the internal capsule laterally and a little bit downward to the cerebral peduncle. So at this time, she could not precisely use her hand to eat. Also, she got a gait problem. So we prescribed a large dose of steroid and stay in hospital for several weeks. After 3 months, you can see most of the edema diminished and decreased, even disappeared, but we could still see some lesion over the internal capsule. So in this case, what we learned is about we should take a very respect to each case. Do not too harsh to finish the operation, especially those patients with a high scar density ratio, which means you would reach a very high temperature. For high temperature, the edema and the heat spreading may be unpredictable. So we must follow the instruction provided by the company. We should do it step by step. First step is to make the direction of the lesion. Second is the testing any adverse effect. And then we could reach the therapeutic temperature. Also, we should take a very alert of those crucial structures, especially below the ACPC plane. So after that, we discussed with our colleague and also Professor Tyra and Professor John from Korea and searched some paper. So we found that the DTI assisted indirect targeting might help. You can see pre-op and post-op. The white arrow, which pointed the pyramidal tract in the internal capsule. So the right side is the post-op. We can see the red arrow head is lesion. So right now, we a little bit adjust our targeting parameters. We will take the consideration of DTI because we set up this center very early in Taiwan. So the MR machine we used is 1.5 Tesla. So after the upgrade of the software, the DTI showed more clearly pictures which could be identified the pyramidal tract. So right now we can see the pyramidal tract. So the blue circle is the target we choose. So we comparing with previously and right now the targeting. It's a little bit, the target is a little bit posterior and lateral as usually we did. It's about 1 millimeter to 0.5 millimeter. So recently we found that using this guide, it looks very nice idea to perform the thermotomy. And this is the IRB case we did. It's a pallidal thymic tract campotomy. It's the target is PTT. It's a tract. It's a nerve fibers. So for this patient, we treated the right side pallidal thymic tract. We can see it. The result seems impressive. Before and after, you can see the initiation, the balancing, and the movement looks improved very much. Also, we can see from the gait, we can see before and after. The patient walk more steady. You can see even from the turning of the gait. It looks nice. And for this target, it have many effects. For we have treated about 9 patients. We found that the balancing, the initiation, and the tremor, and also we can observe the bilateral effect. For this older lady, you can see before and after. For this lady, she suffered from double cancer, and she was now under the chemotherapy. But Parkinson disease, the symptoms bothered her a lot. You can see before. It's not a freeze video. It's the patient could not move. You can see from the pre-operation and after. For this patient with old age, advanced disease, and she is not suitable for craniotomy for the DBS because it will increase the morbidity and the adverse effect in her condition. So for this patient, we helped her with this non-invasive treatment. For one side, we can improve her symptoms. For the other hand, she can keep the treatment of the cancer control. And this is of medication. 1 month later, you can see from the sitting position to stand up, it improved, and the gait. Also, you can see the slowness because she was in stage 4, Honya stage 4. So, but for our neurologist and the patient, even her family, they are very happy with this result. And now I will introduce a little about the X-linked dystonia parkinsonism. The very famous disease is called Lübeck syndrome. You might find this term in the neurologist textbook. Its meaning happened in Philippines, in the Banai Island. So we collaborated with Philippine General Hospital. In the middle, the white brown hair is the dean of the PGH, Professor Ligaspi. She is a neurosurgeon. In the middle with the suit with the tie is my boss. And we visited them and talk about this, how to collaborate and help those patients. You can see this young man. For Lübeck syndrome, mainly they initiated with dystonia, like the truncal dystonia, the hand, the foot, and usually they will happen the Parkinsonism in the late stage. In the end, they usually died with poor intake, suffocation, aspiration. So we have this collaboration and using this non-invasive treatment. Before they have the DBS treatment, they collaborated with scientists from Germany. But for those patients, they usually did not have good economic. They do not have to frequent to reach the outpatient clinic. They usually live very far from the city. So DBS is a choice, but for most of them, it's also a problem because they could not assess the neurologist to adjust the parameter of the DBS. So that's why we consider why not we choose the focus ultrasound to help them. So in this patient, you can see before and after. Because this disease is a progressive disease, so you can see the just after operation, it looks fine, but it's a sex-linked, it's a gene problem. So what we try to do is to help them to improve their quality of life, to help them to get a better life. We treated 4 patients. It looks nice. And we collaborated with Professor Hamura, and recently he published this paper. And this is the post-op. We can see the white arrow in the figure A, it's a lesion. And the blue arrow is a mammothalamic tract. So for pituitary tract, it has several guide points to guide us to reach the target. It's from the Moray Atlas. You can see the pituitary tract on our target here. So it's a short conclusion for pituitary tract. It's because the pituitary tract is more media than the VIM. So for those patients, it's easy to approach. We have the experience of pituitomy using focused ultrasound, but the target is too lateral. So the lesion size and lesion shape could not be well defined. So it's a little bit harder to make a pituitomy. But for PTT tractotomy, it's another choice. So as you see from the Parkinson's disease, we can see the axial balancing, the initiating, and the effect of the bilateral. It looks fine. For pain relief or worsen, we still under study because for our patient, we found that pain improved a lot. It might be on the zona increta because of the heat a little bit over the zona increta. But from XTP patient, we found the pain get worse. We still have no idea about because of disease progression or the heat invade into somewhere. We might have a better demonstration if we have more patients. Another issue is about the axis of the lesion. Using this technique, we can modify the shape of the lesion in RL direction using the mask or the filter. But for the SI direction, we could not modify, which means that in this lesion thermal map, you can see the axis is from medial to lateral, like this post-op. In this patient, the tumor did not control where after the operation, because from the image, I am afraid to move the target more lateral because it will encounter with the internal capsule like this. So we have the knowledge from and the experience from the DBS. Usually we put the electrolyte in anterior to posterior and lateral to medial, which means the vein, the direction, the shape of the ventral intermediate nucleus is like this way. So if the axis is in another direction, the treatment control should be a problem. And we also collect our patients with we classified with the post-op edema degree. You can see from the lesion, the lesion have 3 zones. Zone 1 is the real lesion. Zone 2, like the white, the black circle. For zone 3, it's a white area outside the black circle. For our patient who treated with VIN thermotomy, we classified with from 0 to 4. So, which means we can see the post-op day 1, the edema grade, we will predict the severity and adverse effect after the operation. So this is grade 0. The edema over the internal capsule looks a little bit. And for grade 1, you can see the blue arrow, you can see the internal capsule will outlined by the edema, the zone 3. And for grade 2, we can see the whole internal capsule became more high density, high signal in this T2 weighted image. For grade 3, you can see the zone 2 a little bit into the internal capsule. For grade 4, you can see it's a zone 1 a little bit on the internal capsule. How it could happen, the zone 1 or zone 2 on the internal capsule? Because VIN could not be seen from the image. So we make a indirect target, then make a fine adjustment according to the feedback from the patient. So that's why if we move to lateral, we will danger the internal capsule. So this is a very simple experiment provided by our Taiwan Fire Department. You can see the incense stick model. The fire part is the zone 1, the necrosis area. The pink circle is zone 2, it's cytotoxic area, and the blue circle is vasogenic, which means zone 3. You can see the box with septum. So each anatomy have a boundary between each the anatomy. You can see if the zone 3, even the zone 3 over the boundary, the heat still inside the vein. But if the zone 2, which we will call cytotoxic effect, you can see the heat will spread unpredictable, like the smoke here, into the internal capsule. Also, you can see the heat into the internal capsule. Here's the summary of the edema grade from 0 to 4. We can see almost the adverse effect diminished and disappear and improved after 1 month. But for grade 4, which means the internal capsule will involve the zone 2, you can see the adverse effect became prominent and lasting a long time. Even 2 years, the balancing problem still bothered them, which provided us post-op. We can prescribe some steroid and educate the patient to be careful about the gait problem or sensory deficit or something. Also, you can predict if the edema grade is grade 2 or even grade 3. The paresthesia, the numbness over the thumb or hand, usually will improve and even disappear within 1 to 3 months. So in the end, I would like to thank my big boss, President Ming-He Huang, for supporting us, and also with his great vision to build up this non-incision treatment in Taiwan. We are the first unit in Greater China area, and in the world, there are great increasing numbers of this treatment. I think in the near future, it will be first choice for those patients with movement disorders. And also with his help, we start many clinical trials and hope we could help more patients with movement disorders. Also, I would like to thank my mentor, Professor Taira. With his help, we start from 0. Before this treatment, we have no idea about functional surgery, but after his instruction and help, now we have more confidence in this treatment. And before the COVID-19, we have 2 live demonstration and a symposium with live surgery, but because of the COVID-19, so we stopped the symposium. So we hope in the near future we can meet you in Taiwan and discuss more about this technique. Thank Thank you.
Professor Chang, thank you very much for your presentation. It's been so interesting to see how you compared edema with rooms, showing us how we're touching internal capsule. And for the first time, I've seen such interesting presentation and comparison between physical things and what we usually see on MRI after emergifast treatment. Thank you so much. A lot of questions we have from our listeners and participants, and I would like to invite you to take part in our discussion, and it will be at 2:40 by Moscow time, and I will pass all questions to you during the discussion. Thank you so much. And the next presenter, yes, Dr. Karante, nice to see you. We know that Dr. Karante, he has 2 emergifast treatment cases today. Hope everything is going very well. And great, thank you. Dr. Karante, he is the part of team based in Navarra Medical University, and he's going to present his personal experience using emergifast treatment during several years. And I think his presentation is the longest, it's around an hour, but it was so hard to stop him, and we enjoyed his presentation, and I want to invite you to share your experience. Dr. Karante, please welcome.
Hello, can you all hear me?
Yeah.
Hello?
Yeah.
Okay. Well, first of all, I would like to thank you for the invitation. It's a real honor to be part of this great initiative. We are actually between the 2 procedures, so it's actually good timing, but I will have to go put the frame in 20 minutes for the next one. But anyway, thank you again. And it's also it's a big pleasure to hear Taira Sensei, dozo yoroshiku onegai shimasu, and Chang Jiaoshou, ni de jieshao hen youchu. I took the advantage because I really love languages and I speak Chinese and Japanese. I worked in Taiwan for 3 years, so it's always a pleasure to hear colleagues from these countries, from both countries. And also your presentation was really interesting, and I hope that you like my presentation. And I also hope that I will be on time for the discussion. I hope I finish my first procedure before the discussion.
We're all wishing you good luck on your emergifast treatment and waiting you in our discussion room later. Thank you for your presentation, Dr. Karante.
Thank you.
Thank you. Just
neurosurgery. Thank you again to the organizers, spasibo. And I'm going to talk about my personal experience, which, as you can see in this first slide, has taken places in 2 centers. Initially, I did my training at FINNC in Móstoles with the team of Professor Obeso and Raúl Martínez. And now I am currently working at Universidad de Navarra in Pamplona in the north of Spain. And here you have a picture of my first own patient, because before this patient, of course, I did some procedures supervised, but this one was my first patient on my own. I was pretty nervous, a young guy with essential tremor. And I'm going to talk a little bit about all the procedures. So as I was mentioning, first I worked in Móstoles in this center. It may ring a bell because Professor Obeso, of course, has published a lot of papers and articles about Parkinson's disease. But after 2 years working there, back in 2019, I moved to the competition in Spain, to the other big center, which is the Clínica Universidad de Navarra, under the surveillance and the training of Professor Guridi, who is the chairman and the chief of the neurosurgery department. And this clinic has two centers, one in Pamplona and one in Madrid, but the one where we have the focused ultrasound machine, inside-take machine, is in Pamplona. And this is our clinic nowadays in Pamplona. And if you guys want to know something about Pamplona, or maybe you know already, we have the bull race in July. Well, for the last, of course, after COVID situation, we haven't been able to celebrate this very famous festival. And also it's one of the favorite cities of Hemingway. So these are a couple of things about Pamplona that may be interesting, just to change a little bit the topic. But going back to focused ultrasound treatment, my experience in Móstoles is, as you can see in this slide, a little bit of everything, but I would highlight my experience in subthalamic nucleus lesion or subthalamotomy. And of course, you may know the article, the recent article in New England Journal of Medicine from my ex-team. I did collaborate on that, but since I went to the competition, well, you know, politics. But anyway, I'm really thankful to learn from them. It's a super great team with a lot of experience, and we have also done LIFO treatment, as you can see in the lower part of the slide. So this is Professor Obeso, Professor Martinez or Raúl, and Dr. Marta del Álamo, who is the neurosurgeon who actually taught me everything about the technique itself, whereas my other two colleagues, ex-colleagues, the neurologists, they taught me a lot about physiology, about neurology, of course, semiology, and so on and so forth. The team, as you can see, is very varied. We count with 2-3 neurologists. We were 2 neurosurgeons, 1 physicist, 1 engineer, who are actually geniuses, 2 neuropsychologists. We have also nurses, technicians, etc., etc. And we do the procedure with an ICU doctor. Of course, as I mentioned before, you may be acquainted with a lot of articles, but this is just accepted. This has just been accepted on April 27th on the JNNP. And this is actually very exciting. Here I am as one of the authors because I did 3 of the 5 treatments in Spain. And it's about bilateral thalamotomy. So I really invite you to check this paper. Again, it's super recent. And it's here you have one of the bilateral treatments. So on the left side, it hasn't been inverted or anything. So it's the typical MRI display. On the left side, there's an old lesion. This lesion is about 4 years old. That's one of the first patients that was treated in Spain. And it's the first patient that was treated bilaterally with a new thalamotomy on the right side. And this is the MRI performed 24 hours after the second procedure. Of course, you may know the very big paper in New England Journal of Medicine, also quite recent, end of December last year. And going back to my current center, my current institution, and of course, I'm going to focus more on our current series because I'm more acquainted with how they are doing and all the follow-up and everything. As you can see in this slide, we've done more than 200 patients in around 2 years of time. We've done mostly VIM patients, and from this cohort of VIM, most of them, as you can see, are essential tremor patients. There are some tremor-dominant Parkinson's disease patients. We've done a post-traumatic tremor 1 patient. We submitted the case report, and we are waiting for response. We've done some subthalamotomy in Parkinson's disease patients, which may be one of the interesting parts of my talk today. We've done GPI, and we've done a case of writer's cramp with a lesion in the VOA or BOP. But in this topic, I'm not gonna dwell on too long on that topic because Professor Taira is one of the speakers, and of course he's the big expert. Guriri, my boss, always tells me stories about Professor Taira, and I'm really looking forward to hearing his presentation about dystonia and focused ultrasound treatment in these patients. So the team in Pamplona, as you can see, we are performing the focused ultrasound treatment with Siemens. with the Skyra. It's a 3 Tesla machine. We are 2 neurosurgeons. Here you have Professor Guridi. And then this is the chairman of neurology, Professor Rodriguez Oroz. So we count with 4 neurologists, and well, you can see the rest of the team. And in that case, we're doing the procedures with neuroanesthesiologists, although of course we do avoid sedation as per the usual protocol. In that slide, I'm going back to the previous one, sorry. I forgot to mention that we had 1 case of chronic pain. It didn't go too well, so I actually didn't put it because the result hasn't been very good, actually. So another paper that I have recently been working in and that has been accepted in movement disorders clinical practice is this paper that first authors are actually our colleagues from anesthesiology, from neuroanesthesiology, and it takes into account all the management from an anesthetic point or standpoint. So you can see, of course, the cohort is smaller than the patients that I mentioned because we gathered the data just a little before. Well, what we've found in this paper, besides the prophylactic protocols that anesthesiologists are using for nausea, for emesis or vomits, for headache, is that, and this has also been mentioned by Pineda, who is the engineer back in Móstoles, back in my previous center, that we found a correlation between SDR, skull density ratio, and the amount of energy, as well as with the skull thickness. You may know that some authors are suggesting that not only the SDR is important, but also the skull thickness. And that skull thickness may explain these initial cases when we had a good SDR, but the patient behaved as a patient with a low SDR. So of course, the thickness, the thinner is the skull, the better. And the thicker it is, the worse. And there's also a tendency to find a bad skull thickness, meaning a big thickness, with a low skull density ratio. So they usually go hand by hand, but sometimes we can find patients that are in the middle, meaning they may have a good SDR, but a bad skull thickness, or vice versa. But anyway, that was a collateral finding because that paper focuses more on our protocols when it comes to headache prophylaxis, headache treatment, and as you can see, nausea and vomiting. And we found with statistical significance that woman has an odds ratio 4 times higher for nausea and vomiting than men, and also headache and sonication stop by the patient, meaning emergency button stop, was related to lower SDR, because a lower SDR implies normally a higher amount of energy to reach the same temperatures. As you can see in Pamplona, we are using dexmedetomidine in those cases where the patient may be anxious or may claim he's feeling claustrophobic, whereas in Móstoles we used propofol. So that's a difference that I've noticed between 2 centers. Another paper that was accepted on March, and this time I wrote it with along with my boss, with Professor Guridi, is a paper speaking about foreal field surgery, a hot topic when it comes to focused ultrasound treatment. And Professor Taira Horisawa and our Japanese colleagues have experience in this field, and also, of course, the group from Switzerland, the group from Gallet and Jean Monod. So this is a review about all the papers, all the previous techniques of traditional or radiofrequency lesioning, and also the focused ultrasound lesioning. Some figures from this paper. I think this paper based on Morel Atlas may give us an idea about these other possible targets or potential targets in focused ultrasound treatment. And so, as I mentioned, their protocols are a little bit different between my first center, Móstoles, and my current center. We're going to focus on my current center in Pamplona. The admission is on the same day. We put local anesthesia. This is very commonplace. I mean, I'm sure you guys in your centers are doing pretty much the same procedure. Sedation is only used if the patient is really, really nervous, and we are using desmedetomidine because one of our anesthesiologists, her PhD actually focused on the dosage of dexmedetomidine and the influence on the tremor. So we found that at lower doses and lower infusion rates, there's no influence or not a very significant influence on tremor. That being said, of course, we are trying to avoid it as much as possible. We perform the treatment along to our anesthesiologist and of course neurologist to get the clinical feedback. And we are getting an MRI 30 minutes after the last sonication. This is a little bit different than other centers. I also visited a center in Taiwan. I actually worked in Taiwan for 3 years before becoming a functional neurosurgeon. And I got the opportunity to visit a center in Taipei where they are also doing focused ultrasound treatment. And I saw that they were performing the MRI the day after. And that was also the same protocol or method we were doing in Móstoles. So here in Pamplona, we are doing it 30 minutes after, just it's a different protocol. That being said, again, in the STN, in subthalamotomy, we are doing an MRI the day after. We're doing it 30 minutes after, and we're doing an additional MRI the day after the treatment. The patient is usually discharged on day 1. Of course, if something happened, the patient may stay longer, but the vast majority of the patients are being discharged the day after. And we are doing actually between 3 and 6 month follow-up. This is actually, we have shifted towards a 6-month follow-up because we were seeing that it may be more interesting to see or to compare 6-month MRI with the clinical status 6 months afterwards. These are some MRIs about VIM treatments. I'm not going to stop here too long because my presentation may get too long. I know myself, so believe me, I'm trying to be fast. Regarding the results, so I separated our patients from essential tremor, and in which we did HIFU or focused ultrasound for VIM lesion. And here you have the total number of patients, okay? And the blue part of these columns expresses the patients that have an improvement on the CRST, on the contralateral or treated half or hemi-body, okay? So it's the CRST focused on the treated body, better than 60%. Orange corresponds to an improvement between 20 and 60%. And gray, we could consider that they are the failure of treatments, meaning an improvement lower or inferior than 20%. And we are a private center, and we did a lot of treatments on foreign patients from South America, especially because there's no language barrier and so on and so forth. And we've had a problem with the follow-up. As you can see, there's a loss of patients. We are analyzing the main reasons for this loss of patients and trying to rescue or to find out how they are doing. But this is the results that we have done a follow-up at clinic. So at 3 months, you can see the blue part is still the main part. And even at 6 months, we have 9 patients out of 70 that have a result lower than 60%. On the right side, this one shows the percentage of improvement. And you can see that at 6 months, we have an 87.14% of patients that have higher than 60%. So this slide talks about Parkinson's disease improvement. In these cases, we are using the UPDRS on the treated hemi-body and also the tremor sub-items because we are talking about VIM on Parkinson's disease patients. So this is tremor-dominant Parkinson's disease patients who underwent VIM thalamotomy with focused ultrasound. And again, you can see a little bit the loss of patients that follow up, but yet again, the good percentage of patients with a good result, with an improvement superior than 60%. So these are some similar slides where you can see means and standard deviations of improvements in CRST of the whole cohort of patients. Although, of course, we should, with Parkinson's disease patients, we should focus on, as I mentioned before, on the UPDRS. Regarding side effects, this slide analyzes the side effects at 1 month. So these are the mild side effects. Blue means no side effects at all at 1 month follow-up at clinic. And in this case, it's moderate side effects. And this one talks about severe side effects. So the colors are expressing, as I mentioned, blue meaning no side effects. Red means 1 side effect, and green means 2 or more side effects. So at the end of the day, what we are having here is that at 1 month follow-up, a quarter of the patient do not complain of any side effects, whereas a third of the patient, 33.33%, do describe 1 side effect, which is most frequently gait ataxia. And when they are combined, it's usually gait ataxia and dysarthria, or gait ataxia and paresthesia, but mostly the first combination, meaning gait ataxia and dysarthria. Regarding moderate side effects, you can see that there's a higher percentage of patients who do not complain about moderate side effects, and this goes up to 96.45% when we are speaking about severe side effects. This is a similar slide, with similar figures and plots, but this one talks about the side effects at 3 months. Again, blue means no side effects. And this one is about the follow-up at 6 months. So which patients have permanent mild side effects or longer than 6 months? You can see here a percentage of 16%, almost 17% that have 2 or more mild side effects, 14% 1 mild side effect, but 2/3 of the patients mentioned that their mild side effects have disappeared, whereas this percentage goes all the way almost to 100 in moderate and severe side effects. I don't know if those slides were clear enough, but of course, I'm looking forward to the roundtable, and I hope I can get online to discuss all those cases. I actually have 2 focused ultrasound treatments that day, so I really hope I can make it on time. Anyway, so here you have, these are the typical slides with the espirals. We are doing that within the same treatment. So in the MRI suite, while we are doing the focused ultrasound, A corresponds to pre-treatment or basal status of the patient. This is a patient who had essential tremor, and you can see the progressive improvement of the drawing. And here, that's a recent case. That's a case from last week. And in this case, it was an essential tremor plus with a very, very severe tremor. Patient had been unable to eat or to groom himself or to wash himself for the last 10 years. And here you can see the first spiral, the basal one. This is after the first treat low. Even the verify was not very satisfactory. And that's at the end of the treatment. And the patient, of course, was very happy. And actually, this patient had no side effects. So again, this is, again, a slide about different shapes of our lesions. Again, the MRI is taken 30 minutes after the last sonication. And this slide, the idea of this slide is to see that not always the edema, the vasogenic edema, or the size of the lesion goes along or corresponds to side effect. So moving on to pallidotomy, we've done a few pallidotomies within a clinical trial, an international clinical trial from Insightec. So of course the results and the data cannot be shown or undisclosed. I also did some pallidotomies at Móstoles. In the case of pallidotomies, I would say that we are facing 2 main difficulties. One of them is difficulty in reaching the temperature because we are getting quite far away from the midline. So the angle of incidence makes the capacity to reach higher energies lower compared to STN or to VIN. So that's why maybe PTT may be an interesting target because it's closer to midline. So of course the energy efficiency may be higher. That being said, with pallidotomy, we were also having issues with facial asymmetry and hemiparesis due to the, as you all know, the anatomical relationships between the GPI and the internal capsule, which is medial and posterior to the GPI. So of course we have to be careful because we want to get as closer as possible to the famous Leitinen corner of the GPI. So this moving to subthalamotomies, I'm gonna show you some videos. I'm sorry I didn't have time to edit them, but this is a patient, a 62-year-old female patient with Parkinson's disease, 9 years of disease, right-sided predominant, as you can see. And so we proposed the left subthalamotomy. You can see the scores of pre-treatment, and this patient, these letters mean that she had tremor, bradykinesia, and rigidity. She had the three main motor cardinal symptoms. Again, this is before treatment. You could see that she mostly have a resting tremor. Action tremor, as you can see, is not present. And I'm going to move forward, sorry, because this, as you can see, is quite normal. But then let's see if we can see her bradykinesia and her rigidity. So here we have with the finger tapping maneuver, and you can see how the amplitude gets smaller and smaller. And then the grasping or opening and closing her hand. Again, maybe it's a little bit less obvious than the tapping. Here we have the reemergence of tremor. And well, when it comes to pronation and supination of the hand, she also shows bradykinesia. This is our neurologist, the chairman of neurology, Professor Rodriguez Oroz. Again, it's, of course, you all know that's teamwork. She's checking on the rigidity. I think I remember she had the rigidity between 2 and 3, depending on the joint that we examined. Okay, so moving on to the next slide. This is after a couple of treat high sonications. And then I'm gonna move on to show you the post-op status. So here we are checking both for reemergence of resting tremor. Also, indirectly, we are making sure she has no pyramidal symptoms or no hemiparesia. And as you all know, with subthalamotomy, sometimes we can find sort of, well, of course, treatment dyskinesia. In this case, we're checking the bradykinesia of the foot. You can see the tremor on the left side a little bit. Here, there you go. Could you see that she had some leg dyskinesia with this adduction and internal rotation movement? And this one was on our first lesion spot on the subthalamic nucleus. If I have time, I'm going to explain to you what we do, what we usually do, and what I learned in Móstoles with Professor Obeso is to perform lesions or therapeutic sonication at 3 spots within the subthalamic nucleus. So this is the MRI 30 minutes after. And I know what you all think when you see this. Oh my God, look at this edema. Look at this. This has gone to the internal capsule. But yet again, surprisingly, this patient had no hemiparesis, and it's mostly vasogenic edema. And here you can see a figure that looks like a cone. So if you search on the literature, this may correspond to Edinger cone, which come from Wilson's pencils. These anatomic structures make reference to the fasciculus thalamicus. The fasciculus lenticularis. Sorry. My boss, Professor Guridi, would kill me if he hears me. So this is basically the steatofugal fibers that go from the pallidum all the way to the thalamus. And this again is the FL. The ansa lenticularis has another direction. And these are going to come together on the foral fields and form the fasciculus thalamicus. So I hypothesize that maybe this edema is marking all these fibers. It's just a hypothesis because, of course, we cannot do an autopsy on the patient because the patient survived the treatment. So again, as I mentioned, 3 spots of lesioning, 2-3 sonications per spot. So that's a lot of sonications. That's far more than on the VIM. So of course, this sonication has to be as short as possible, because by doing so, by doing very short duration, these sonications are very precise, and we are trying to avoid the surrounding edema. Again, this makes reference to the aforementioned patient. This is the data from the treatment. 3 spots, L1, L2, and L3. As you can see, before going to a treat height, we did verify on each spot. And we depart from quite posterolateral spot on the subthalamic nucleus, but then we move posterior and lateral, and that's the tricky part. The L2 is the dangerous lesion because we're getting closer to internal capsule. And then on the L3, what we usually do is we go back to L1 and we change the dorsality, because even if we are escaping a little bit from the subthalamic nucleus and we are a little bit dorsal to it, we know from the experience from Professor Guridi and from Professor Obeso with radiofrequency subthalamotomies that this sonication a little bit outside of the subthalamic nucleus may be very good both for tremor and to protect from dyskinesia. So going back to our patient, the 62-year-old female patient that you saw during the treatment, this is the day after the treatment. Remember that we treated the right hemibody. So you can compare, actually before treatment, her left hemibody was barely noticeable by the patient, but now actually she was actually complaining about her tremor on the left side because she realized that actually her left side has also symptoms. But of course, as you all know, focused ultrasound for the time being is unilateral. So here we are talking to her to see if we trigger some resting tremor, and both the hand and the leg are fine. Here she's gonna start to count in Spanish backwards. Well, you know the drill. And here it's you can see the thumb, the left thumb compared to the right thumb with a typical Parkinsonian tremor. And again, if we move forward, her hands are getting more shaky on the left side, whereas the right side is perfect. So here you have the post-op UPDRS at 6 months. So if you compare the whole UPDRS, you can see the great improvement. Both are in off medication from 41 to 16. And when we check for the items on the right side, we are going from a 26 pre-operative or pre-HIFU to almost a 0 on the right side. As you can see, she at 6 months post-op, she had a little tiny bit of resting tremor on her right leg. She was super happy. In fact, we actually asked her family in case she wasn't too happy, in case we didn't make some hypomanic status, but it was all right. She was just very cheered up, but nothing out of the ordinary or nothing that couldn't be controlled. And she also noticed a great improvement in gait and also cephalic tremor. Again, that's another video. Let's see if we can see her bradykinesia. I don't know how long it's taking. I mean, if I'm getting too slow or too long, I hope you're not getting asleep. You're not falling asleep. Well, so this is some action tremor. In this Parkinsonian patient, is not that relevant. Well, you can see that there's no dysmetria. That's the non-treated side, left side. And again, another video. I think that's the one with the bradykinesia. Sorry, that's again the tremor. Okay. Well, sorry, this was again a video about tremor, but here you have the gait, and you can see her right side, how her arm and her leg are moving freely. This patient, as you may have noticed from her scalp, had actually hair implants. So I was actually really worried about the possibility of ruining her hair implants with the focused ultrasound. But the hair was actually growing back properly. But of course, on the informed consent, we added that. I don't know if any of the other speakers or the listeners had experience with the patients with hair implants. But well, that's another curiosity about this patient. Let's see if you can see finally the expected bradykinesia. Here we are. Let's see if we can see the, sorry, I'm combining. Look, check the difference between the resting tremor. So here you have the hand, the opening and the closing or the grasping. You can see the amplitude is really nice. The patient was really happy. When we're doing that, it may seem that, oh, look at the tapping. Okay. I was saying that when we see or we check the bradykinesia, you can see that maybe her right leg, we have the impression that it's having tremor, but here we go. We separate it because it may be transferred from her tremor from the other side. Rigidity was 0, and this is the non-treated side, where you can see again that the amplitude goes lower and lower. And the non-treated side was actually pretty decent, was considered her better side. And here you see, if you remember, the right side had far more amplitude and no bradykinesia, and on this side, we could give her a certain degree of bradykinesia. So subthalamic nucleus lesioning, of course, is scary, but it's more scary than VIM because we are far lower near the brainstem and near the pyramidal tract. But yet again, if the sonications are very precise, very short, and well located, I really believe that we can help patients, Parkinson's disease patients, more or in a greater way than with VIM thalamotomy, especially for, as you all know, for symptoms such as bradykinesia and rigidity. So again, this is the paper about the comb that I was telling you, Edinger comb, which comes from Wilson pencils. So Wilson pencils is a structure on the pallidum, and the comb, as you can see, is joining the striatum and the subthalamic nucleus, and it crosses the internal capsule. So I found this paper and I thought it could be interesting to compare it to the MRIs that I showed you previously. So here you have another patient, 64-year-old male, 5 years of disease, predominantly on the right side. Here you have the scores. And this patient had complained mostly of bradykinesia. He also had tremor, but he was complaining of bradykinesia. You can see his gait. That's before the treatment, even though his head is already shaved. But that's his discretion before the HIFU, okay? So you can see the absence of automatic movements on the right side when he walks, and how he drags his right leg. And it actually took him a big effort to walk and to stroll around, whereas tremor wasn't really very problematic. As you can see, we examined action tremor and he could do his daily activities. So here we have the pull test. Quite decent. Again, this patient had a better score than the previous one. This is again before HIFU. Sorry, I'm gonna move on a little bit because I know that he starts trembling around 40 when we stress him. Telling him about the price. But as you can see, the tremor is really, really mild compared to the bradykinesia and the rigidity. So we could say that this is kind of different patient than the previous one. Again, here you have the tapping, finger tapping. He considered himself very clumsy. He used to do manual activities, and now he said that he wasn't able to do so. Now we're going to move on to the opening and closing of the hand. This is no slow motion. Again, this is his normal movement. Left side, which is less affected. Of course, you can see the difference. But with the subthalamotomy, we were aiming to reverse that on his right side, which was also his dominant side. Pronation and supination of the hand, pronation and supination of the left side. Now we're going to the feet. Well, now we can check how he stands up. The amplitude of the stepping on his left side is bigger, and on the right side, you can see that how it decreases progressively. Okay, so that was the pre-op status of this patient. I think I'm gonna skip that video because I think it's quite the same again. Sorry about the editing. It's been a really busy week. So again, skull density ratio of this patient was 0.50, but in this patient, we had serious problems to raise the temperature. So I wasn't really happy with this treatment, because if you check, the temperatures are, from our standard, are really low. And the other thing is that the seconds had to become longer and longer. And you can see that the energy was, at that time, before the update from InsightTech, this was top, and 1,500 watts. So if people from InsightTech is watching me doing this talk, they're gonna, they're gonna be scandalized. But we had to struggle, and we had to push to the limit to get a good result, and to get temperatures that are actually not super therapeutic, and with very long durations. So I was really worried about this case. But surprisingly, the result was really good, even though, as you will see, the image is not very convincing. Again, so not only the temperature, but the image, this is the 30-minute after HIFU MRI. This is T2, and we can only see edema, basically. I don't see the nice necrosis. And actually, of course, we have to say that this edema looks to be in the prelimniscal radiations and even the CTT, and not even in the subthalamic nucleus. So again, not really happy about this treatment. But again, when we check the SWI, I really think that SWI sequence exaggerates the findings, because of course we didn't do that many lesions. And in this case, you know that the temperature wasn't really nice, as you saw before. But the location looks far better than on the T2. The location of these lesions looks that it encases the subthalamic nucleus on the dorsal part, because here we are losing the red nucleus and we're still having the lesion. So this is the patient 6 months after the treatment, and this is how he walks without medication. He's in off state after HIFU state, 6 months. You can see his right side, how good and smooth it's moving, especially the arm. And if you are a good observer, you may have seen his right foot. We actually studied that. We did a study from his pyramidal tract with our neurophysiologist, with transcranial magnetic stimulation. And there was no problem with his pyramidal tract, but there's some sort of weird movement on his foot. Our colleagues from neurology didn't categorize that as a dyskinesia, but yet again, it wasn't annoying for the patient, and he actually felt very free. This patient had also a somewhat little euphoria during the first months after the treatment, but no cognitive decline, or no mania, or no gambling, or no impulsivity. Here we're checking the resting tremor, that's left side, so that's not really interesting. But if you remember the gait, we've seen a very big improvement. And here you have the post-HIFU UPDRS went down to 9 on off status. And on the right side, we basically have a resting tremor of 1 on the arm when we stress him a lot, and a little bit of bradykinesia on his right foot. You could see the tapping, the improvement on the tapping of the patient. I'm sorry, I think I'm really getting really long talk. Look how nice the amplitude now is on the right side, AKA the treated side. And look at the pronation and supination. So this patient was really happy, even though I was really worried about the treatment because temperature wasn't really good. Now it's been a year that he's been treated, and his examination and his score is overlapping the one that you are seeing. So we are very happy with this patient. Moving on, so this is the subthalamotomy, the MRI of this patient, again in T2, barely noticeable, whereas SWI shows us a lesion encased in the subthalamic nucleus. This patient had also lesions at 3 sites. And these are other slides about subthalamic nucleus, but I'm going to skip videos to make it short. These were first cases. One thing that really annoys us is that on the coronal side, the lesion is always perpendicular to the disposition of the subthalamic nucleus. And that was also a thing that irritated Professor Obeso. But I think there's nothing we can really do about physics and the shape of the lesion, besides maybe trying to mask the transducer. But even by doing so, I think the shape that we're getting on the coronal side is always like that. These are additional slides about our 17 subthalamotomies that we have performed so far. Remember that in Móstoles, I had experience with a lot more subthalamotomies. And this is a slide checking the X coordinate. And it's actually pretty dorsal, and we do admit that. But we try to stay on the subthalamic nucleus, but again, from the experience from Professor Guridi and Professor Obeso, and from their experience from subthalamotomies in Cuba, we know that escaping a little bit the subthalamic nucleus on the dorsal part protects from dyskinesia. I'm going to skip these slides if you are okay with it, because these are some slides about my old center, and actually now they have a pretty bigger number. So this is only a series of 21 patients with a follow-up of 1 year. And you can see from 21 patients, at 24 hours, the predominant side effect was gait ataxia. But at 1 year follow-up, the majority of these side effects disappeared. So this is an experience. I'm not telling you anything new. So that's why I'm going to skip that, if it's okay with you. This is a study that our engineer in Móstoles did about the shape and the characterization of the lesion. You know the areas of Wintermark, but we also wanted to characterize a series of patterns of the lesion at 3 months follow-up MRI. And we have the pattern 0, which is a lesion clearance. Of course, we have patients with no observable lesion. And this is not directly related to the clinical outcome, meaning that some patients may have a very big lesion at 3 months and had a relapse. Another patient may have pattern 0 and may be very well clinically. So here is pattern 1 with a hyperintense T2, and here is pattern 2 with a hyperintense score T2. This is just to show that we are using these analyses with our cases nowadays. So lessons learned, and I'm trying to go to the end of my presentation. I hope you all had some coffee. So the best response with VIM, is it the posterior edge? Should we shift towards the DRTT? Should we go to an anteromedial, the so-called hotspot, recently published by Lozano and his group, and also described by groups from UK? Are the small lesions are associated with less adverse effects? The patient is discharged very happy because he can walk by himself, he has no hemiparesis, he has no paresthesia. But are these patients at a higher risk or a significantly higher risk of relapse, of recurrence of tremor. Whereas big lesions may produce adverse events, may make us refer the patients to our rehabilitation colleagues, but maybe there's a lower risk of relapse. The adverse events are variable, are difficult to predict, as you can see on the slide, and I think that they are not only related to temperature or even location. Sometimes there are maybe some factors such as the patient, the atrophy, the premorbid status, and so on and so forth. So this needs to be studied more thoroughly. And it's very important to establish a relationship between the temperature, the vasogenic edema, the number of sonications, the duration of the sonications, because if you review the papers, the authors don't really mention the duration of sonications. And I think that may be an interesting point, because in Móstoles, we learn from people from Inside Tech that it would be better to do short sonication and a higher number of sonications, because they should be more precise and leave less edema. Whereas when I arrived in Pamplona, Professor Guridi learned or had the savoir-faire of doing longer sonications. And when I say longer, it was 4 or 5 times longer than the ones I did in Móstoles. We changed that here in Pamplona when we started doing subthalamic nucleus, because we had a couple of unfortunate events on the first subthalamic nucleus with hemiparesis due to vasogenic edema. So after checking everything, we started doing the short sonication model. But we don't know which one is better. So it would be interesting to compare these parts. I don't know if the rest of the speakers have feedback about this topic. So more slides about VIM treatments. Again, I'm not going to stop here too long because of my time. I already excessed, I think. But here you see very nice lesions with almost no vasogenic edema, only necrosis and cytotoxic edema, so area 1 and area 2, zone 1 and zone 2 of Wintermark. And other questions yet to be answered. And of course, some guys in the audience are far more experts than me, especially they also have a background with radiofrequency lesioning. When to stop? Is there a threshold or transition between the penultimate and the ultimate sonication? Professor Guridi always say that on the last sonication, that is 70–75% of the treatment in terms of efficacy, of duration, and even adverse events. Is the estimated temperature trustworthy? Should we do it systematically? Should we base our temperatures and energies on our experience with other patients with the same skull density ratio? Again, the topic of the duration of sonications, and I think that's important. And also strategies to locate VIM, STN, GPI. Of course, nowadays with the imaging advancements, you have tractographies, atlases, etc., etc. And another topic or questions is the strategies to avoid cavitation, but that's really regarding to the technique. So as I mentioned before, there's a recent paper from the group of Lozano that analyzes the possible real hotspot of the VIM lesioning. But funny as it may sound, when you talk to Professor Lozano, well, I don't talk to him, but Professor Guridi knows him very well and they are good friends. He still sticks to the classic coordinates, so to the 25% ahead of PC on the Y, because this change mostly is related to the Y coordinate. So of course, also there are questions about Parkinson's disease patients. Is there a higher risk of relapse when we do a VIM lesion? And this topic has thoroughly been addressed with radiofrequency lesioning, because there are series with VIM, with STN. The topic of, or the subtype of resting tremor and also the leg tremor may also be interesting, because as you may know, a lot of authors imply or describe the possibility of having, an influence from a pallidothalamic or a striato or a basal ganglia pacemaker that is different than the cerebellothalamic influence of the tremor in essential tremor. But I think in a lot of patients, we have a combination of both. So in Parkinsonian patients, should we go for subthalamic nucleus? Should we go for GPI and forget the VIM? Or should we go to PTT? That's also a very new possibility, or to foral field, or to caudal zona incerta. So there are a lot of questions that are fascinating and very interesting. Again, strategies to locate VIM. In my current institution, we are doing that. So the classical coordinates. In cases with a large third ventricle, we correct to 11 millimeters from the third ventricle wall, according to Tasker classical papers. The Y, we're doing 25% of ACPC, and the Z, the dorsoventral plane. So here I found a difference as well, not only the duration of sonications, but also the location of the Z, because in Móstoles, with the team of Professor Obeso, we did the lesions at the ACPC plane, whereas in Pamplona, we are doing 2 millimeters dorsal. Sorry about the above, if I'm correct. And if I want to use the correct nomenclature, I should say dorsal to ACPC plane. Other questions or other methodology issues are, should we look for VC as a reference, especially when we are lost, when the verified sonications are not good? Which movement should we do inside the VIM? So I found also different strategies. And is the tractography useful? So if you review papers, there are several possibilities and combinations of coordinates. And when I arrived here, Professor Guridi made me read and study a lot of papers, and that was one of them. This paper is from the group of Lozano, and this was to convince me of the 2 millimeters dorsal from ACPC plane. So in terms of nucleus and tremoric neurons, he convinced me. But I also think that the ACPC plane may be interesting because you get the fibers that are getting in the thalamic nuclei. So I think maybe both stances may be correct, or not completely wrong. So it's also a topic of discussion. I know from different centers that some do the sonications at 2 millimeters dorsal, some do it at ACPC plane. Anyway, what we are doing is doing some changes on the Z plane. So when we're starting 2 millimeters dorsal, we usually go 1 millimeter ventral. And these are slides about how the tractography can help. And interestingly, in some studies about relapsing or recurrence of tremor, we see that the DRTT reappears when the tremor reappears. So what to do inside the VIM? Well, there are several movements. Again, these are some slides with the Schalterbrand atlas. So of course, if we have capsular effect, we have to go medial. If we have sensory symptoms, we have to go anterior. Well, I'm not making you this. I mean, you all know that you are experts in the topic. So of course, and what we do, when we started doing, that's the last part, if we see no benefit or no side effect, then we usually try to go posterior, searching the paresthesia. But recently, sometimes we change that strategy and we aim towards the DRTT. Again, inside the VIM, even if we are having a good response, I think we should take into account the somatotopy of the VIM and do some little movements, especially in those patients where they have a very complex tremor that affects different joints. And I'm saying that because in some patients, we are seeing not such a good response in terms of proximal tremor. And of course, in patients with leg tremor, we have to risk it and go a little bit closer to the internal capsule. So this is an example, and this is a slide from my colleague, Raul Martinez. So I have to thank him, and this is, of course, his great job of one of the patients we treated in my previous institution. And you can see a series of movements that we did according to the clinical feedback. And I would like to highlight also the short duration of our sonications as compared to other centers and other recommendations from Insightec. And this is the result of this patient, both the image and also the result at long follow-up. And to finish, there are a lot of hot topics about focused ultrasound. So basically, in my case, I always love to talk about subthalamic lesioning or subthalamotomy. both subthalamic nucleus lesioning and both subthalamic area lesioning, which are different. Also, the hot topic about the resting tremor and the leg tremor. Which target should we choose in Parkinson's disease patient? And I know maybe Professor Taira and Galei and Horisawa may add to this question the PTT or the foreign fields also. But from my point of view, we should also address the question of sonicating white matter versus sonicating gray matter, because I really believe that there may be a difference in terms of sonications, temperatures, number of sonication, and size of the lesion when we are lesioning a tract or when we are inside the VIM nucleus. So this is something that should also be addressed from my point of view. And then there's also a very big hot topic, but also a forbidden topic. It seems to be a taboo because there are very few papers that talk about recurrence and redo HIFU. I actually had 4 or 5 papers in my mind, which are case reports of redo treatments. So management of relapse, what should we do? Relapse of tremor in ET, should we redo? Should we go to caudal zona incerta? Should we move towards more the UK target, the target a little bit more anterior and medial than the classical VIM? What should we do in tremor dominant Parkinson's disease patients? Should we go for STN or PTT? Or should we do a redo VIM? And what should we do in dyskinesia in patients that has undergone a HIFU subthalamotomy? Should we do a pallidotomy, emulating the classical procedures, with radiofrequency lesionings? Should we do a PTT? So of course, we can draw so many conclusions from all this long talk. Again, I apologize for the length, but I think that focus ultrasound is a promising, and I would say an already very well-established technique, but we still need to do very detailed and very well-designed studies, especially when it comes to long-term outcomes and adverse effects. Bilateral VIM lesioning should be studied with bigger and better randomized clinical trials than the one that I recently published along with my colleagues from Madrid and from Zurich, because it's a short series. Targeting must be personalized. I think that's essential in each patient, and we should combine indirect and direct findings. And the subthalamic lesioning or subthalamotomy provides a great improvement for patients with Parkinson's disease, but of course, patient selection and technical savoir-faire are crucial. Well, here is the end. Thank you again for everything. Spasibo. I tried to put pictures of things that I love about Russia, but I mean, I would be talking for an extra 3 or 4 days, but here you can see some of them. And for instance, Bolshoi Ballet would be another one. Anyway, thank you very much. I'm really humbled to be able to participate in this Congress. And I really hope I can be there for the roundtable and the discussion, because as I mentioned, on Wednesday, I'll have 2 treatments. And feel free to contact me via email, via LinkedIn, even Instagram, which is the way that I got to know the team from Professor Galimova from Russia. So that's how we actually started. And I also had the opportunity to watch the incredible video of the spiral. I have to congratulate your team for doing such a great job. And I think that's it. And sorry again for the length. I'm looking forward to hearing from all of you and to have a very enriching discussion. And of course, from this Congress, start networking and getting in touch with very great professors and great specialists as the whole audience. Thank you very much, and I hope you enjoyed my presentation.
Dear Karante, thank you very much for your inspiring presentation. We were very touched with these Russian pictures, even with Russian caviar. Thank you so much. We are waiting you, and we will be happy to meet with you in our medical side. And we're really happy to be able to collaborate with you through all these digital platforms right now. But thank you for your great speech. I'm very excited and very happy to present our next participant, Rick Schollhorn, Vice President covering all neurosurgery for the InsightTech company. Rick Schollhorn, please, with your welcome message, we're very happy to hear something new from the InsightTech company.
Hello and good afternoon. My name is Rick Schollhorn from InsightTech. I'm Vice President of the Neurosurgery business at InsightTech. I would like to thank Dr. Galimova for inviting me to present at your conference. My agenda will be relatively brief. I was asked to give an overview of our platform currently used for ablation with focused ultrasound, as well as talk about some of the investigational uses that are ongoing today with focused ultrasound in the area of neurosurgery. Start by just briefly reviewing that, currently the system that we are using commercially around the world for ablation for functional neurosurgery. I think many of you in the audience are aware there's an increasing commercial and scientific interest in the technology, obviously being a non-invasive option for neurosurgery provides significant advantages for patients around the world. At present, as you're aware, there's quite a number of articles published in the medical literature. And on right, you can see that there are quite a number of installations being put in place around the world. These numbers show the number of sites that are currently operating or are soon to be beginning to operate with focused ultrasound in neurosurgery. I think you're also relatively familiar with the platform, using MR guidance to focus 1,000 beams of ultrasound at a very specific focal point in the brain in a way that we can increase the temperature to a level of ablation without opening the skull. You also may be aware that in the current state of the technology, the ablation targets are limited at the moment to within several centimeters from the center of the brain or from the ACPC axis. This, of course, makes the product very applicable for treating movement disorders with targets in the thalamus, targets in the pallidum, and around the basal ganglia. However, the product is being used successfully today, as I mentioned, in nearly 100 sites around the world. We anticipate at least more than 3,000 thalamotomies will be performed here in 2021 around the world. And most of those treatments are routinely being done in under 2 hours, as I'm sure you've hearing through the conference here. To give you some idea of some of the things that are being worked on to improve the product and expand the indications, at present, we at InsightTech are working on improving the software workflow with the product. There is room for making the procedure even more efficient and faster than it is today. Also to allow the ability to bring more images into the session and fuse them to the treatment. For example, DTI imaging, which may be helpful in fine-tuning the targeting for some of these structures that are difficult to see under MRI. We're also in the process of adding 3D thermometry, which will also speed up the procedure, the ability to see the heat and the temperature that you're creating in all 3 dimensions at the same time. And we're also working on improving our focusing algorithms to reach more lateral targets. Obviously, we would, I think a number of our centers around the world would be very interested to use a product like this for doing epilepsy surgery in the temporal lobe. And we're very interested to do this, but we must improve our focusing algorithms and our ability to generate enough heat in these structures to be ablative. Give you a little bit of an idea of what is some of the research in new indications that's going on with the product at the moment, the present 650 kilohertz exablate commercial product. There are clinical trials ongoing at the moment for doing bilateral treatment of essential tremor, trials focusing on pallidotomy for Parkinson's disease. There is some work being done on focal dystonia with the thalamic target. Another thalamic target that's under investigation is the anterior nucleus for generalized, secondary generalized epilepsy. There has been some work attempted with hypothalamic hamartoma, although this gets close to the edge of how far the product can currently reach with ablation. And also there's investigation going on with thalamic targets for neuropathic pain. And as I mentioned before, the high level of interest in the temporal lobe and hippocampus for epilepsy, and we at Insightec are working to continue to improve the technology so that we can have that procedure be available in that patient population. So that's a little bit of an overview of what's happening with the ablation system and where we're attempting to improve it and also to expand its indication. I want to spend the last couple of minutes just describing for you some work that this is relative to an investigational version of our transducer, is able to open the blood-brain barrier with focused ultrasound. This graphic here shows you a picture of a blood vessel here in the brain with an intact blood-brain barrier. Here you see these white circles are actually microbubbles injected into the circulation, which are then put underneath ultrasound and are able to resonate and stress the capillary wall and open the blood-brain barrier. And as you see, that allows, of course, the ability to put, it allows the ability to put possibly various molecules, chemotherapy, other drugs, other types of therapeutics into the bloodstream. So this is a very unique tool and one that has generated a lot of interest. Among researchers around the world. There are a number of these investigational units that have been installed and are currently doing very early safety and feasibility work in humans of opening the blood-brain barrier. Some of this work has been published. Here's a few of the articles you may have seen, or maybe others here at the conference may be speaking to. The first work done in humans was out of the Sunnybrook Health Center in Toronto. This was published in Nature Reports in successfully opening the blood-brain barrier in a patient with a glioblastoma. You can see the gadolinium enhancement post blood-brain barrier opening with focused ultrasound, verifying that indeed the the barrier was open. In fact, at present, over 200 such treatments have been performed with, at present, no concerns of safety. The barrier has been opened in each of these cases and has subsequently been shown to close within 24 hours after the ultrasound exposure. And as I said, this work is being in very early stage just to demonstrate that the tool, as I said, is safe and is effective. There are a number of other studies going on after that first publication. There have been a couple of subsequent publications, one involving Alzheimer's patients, one involving ALS patients, both from the Sunnybrook group, also in Toronto. And there's also another publication that is now available on Alzheimer's from a group in the United States, as well as another publication on Parkinson's disease from the group in Madrid. As I said, again, each of these studies have been, to date, run with no adverse events. Sorry about that, I inadvertently moved the slide forward. I wanted to just kind of summarize the work and the picture. So again, just to summarize, we are continuing to develop the technology as well as to continue to expand its use to new indications. This just to remind you that we have at current a system operating at 650 kilohertz that does primarily ablation, which has been commercially approved around the world for essential tremor and in many parts of the world also for Parkinson's disease. It's being applied investigationally in pain, also in epilepsy. And then the other technology, low frequency focused ultrasound, more oriented at opening the blood-brain barrier, which has begun very early investigation in glioblastoma, Alzheimer's, and other neurodegenerative diseases. So thank you very much. And I hope you have an excellent conference. And again, thank you to Dr. Galimova for the invitation.
Thank you very much, Rick. It's been so exciting to see the coming future and what's going on in Inside Tech company, telling us more about in what fields we should work and to what questions we should pay more attention. And let me introduce our next speaker, Igor Buzaev. He's interventional cardiologist, one of the co-founders of our medical center, and the person whose idea was to organize the first focused ultrasound non-invasive neurosurgical congress in which we are all participating today. And his speech is devoted to the first month of our work and how we did all steps to establish digital platform, connect with Inside Tech specialists, and be all time and be in contact and move the world to go around. Please, Igor, welcome.
Hello, my dear colleagues, ladies and gentlemen. First of all, I want to say that... Hello, my dear colleagues, ladies and gentlemen. First of all, I want to say that I'm very honored to be the part of your team. I'm an interventional cardiologist, and usually I'm working with the heart using small punctures, but you are doing great job without any punctures, without any incisions. So it's so inspiring that I really was inspired to participate in this project. And I will talk about the role of digital technologies in implementation of complex medical procedures in COVID-19 era. At April 2020, we finished preparations of our center, but COVID-19 has blocked the opportunity to invite proctors to start treatments. It was really problems because the patients was waiting, and we had a private center with a huge bank loan that we need to pay, and of course we wanted to be the first in Russia. So this question I already asked myself at March, because in March I prepared the patient for complex endovascular mitral paravalvular leak closure with my friend and teacher, Italian professor Eustachio Onorata, who is world leader in this field. He planned to arrive to Ufa and join my team to the operation, but at the middle of March, his city, Brescia, was one of the first cities was blocked because of the quarantine in Italy. So the patient was really sick. He has a large PLD, a paravalvular leak, and open heart surgery was impossible. So my solution was, could I ask help online? And there is a TV report in the right corner of the presentation when we are discussing with Professor Onorata the techniques of operations. So the case was successful. In 6 hours, we closed this paravalvular leak. And we thought, what if we make the virtual presence of InsightTech products in operation room using several cameras and screens? We thought, let us try to implement the education stage and to make, for example, DQA under online supervision, and then decide maybe to start virtually, distant. InsightTech understood our problems and led us to try the DQA Phantom, and we succeeded in that in 1 week, and that's why they allowed us to do the first human case at the 5th of May. So there is a year anniversary today of this case. So one of the problems to solve was, first of all, we need to broadcast MRI images to the proctors, to the London and to the Spain, and we need to broadcast the fuse screen, the computer console, and we need to visualize MRI table and all processes doctors and nurses doing with the patient, with the equipment. So, and for input, we need to InsightTech instructions and to their help to control FUS console, because we was not very familiar how to work with this program. And for virtual presence, for MRI images, we asked GE to allow us remote desktop for the console, but GE didn't allow it, so we tried to use HDMI cable to USB, and it didn't work too, so we just used the usual web camera on the screen. We were putting it on the table, and it was broadcasting the screen outside. And for virtual presence, for focus ultrasound screen, the company InsightTech allowed remote desktop, and using VNC connection from InsightTech, proctors can control FUS machine and help us working with interface or program interface of the machine. So MRI room was another problem, because in MRI room we cannot put the devices that make noise. So Microsoft web camera at the ceiling was working well only 1 month, and then we don't know why they started to noise, and we moved this camera to the MRI window, because in 1 month we was familiar with some activities, and we already didn't need to have this near position of the camera inside the room. So this is the view from the camera from the ceiling on the MRI room. This is the view from the window. And this is how Microsoft Teams is working with the proctors. The proctor from InsightTech, the clinical specialist Paul Rek, and representative Dr. Daniil Malchanov, and all our team making the MRI FUS and TESA case. So for the processes, we use laptop with Microsoft Teams and webcam. And we use 2 laptops, one portable that was with some employee, and another was near MRI and FUS machine keyboards to work with neurosurgeon Brizida Maratona. So this is Rizida Maratna and Dmitry Krikotin, who are the leaders in the first operations, and this is their work, MRI focus ultrasound guided MRI guided machine. So this is how we made the tests of the patient neurological test. You see the IVR with computer who showing the proctors the results of the operations, and after that 35 treatments were performed and all was done successfully without any serious complications, and solo license from InsightTech we get on 31st operation. So all results were today previously presented by Rizida Galimova and Olga Kachimaeva. And in conclusion, I want to say that implementation of complex medical procedures is feasible if we have such a dream team. Thank you to InsightTech chiefs, Paul Reck, Tessa Case, Daniel Manchanov, our engineers, and all our dream team. Our dream team is listed in this slide. Rizida Galimova, director, performing neurosurgeon, who was inspired in the US with this technology and put it in Russia and make the first center. Dmitry Krikotin, radiologist, Elvira Zakirova, Olga Kchimaeva as neurologist, anesthesiologist Agasha Leshov, Tatiana Koveshnikova as technician, and Ivar as engineering specialist. Online on the operation was covered by our Professor Shamil Mahmudovich Safin, who already had the welcome speech. And so I'm very glad to be with you, and I hope, and I want to say that it's feasible. If you want to help the patient, you can use some digital tricks to work overseas. Thank you very much.
Thank you, Igor. It's been so nice to remember those. Thank you, Igor. It's been so nice to remember those days. So our memories tend to forget a lot of. So thank you for remembering and putting very important points on what we have done and how it was very exciting and difficult. The next speaker is my colleague Olga Kachimaeva. She's a neurologist. She's the first neurologist in Russia who performed first MRI guided focused ultrasound treatment. She's our brain, she's our eyes, heart, and everything. And she is the advocate for all our patients going to the treatment. So she's going to give very quick analysis of our work according to patients' results, according to what UPGRS we have before and after, what complications we had. So Olga Kachimaeva, please welcome.
Good afternoon. Thank you very much for these warm words. It's a great honor and a great pleasure to be here today. Thank you very much for this opportunity, for this pleasure to listen to the presentations of the outstanding researchers, to get new knowledge, to set new goals. Well, thanks a lot. As I understand, my lecture was pre-recorded, so I'd like to ask to start it. Thank you very much. Good afternoon, dear colleagues. It's a great honor to be here today. Thank you very much for this opportunity. I'd like to speak about neurological outcomes in patients with movement disorders treated with magnetic resonance guided focus ultrasound. I'd like to speak about literature data, and I'd like to present our own results. Pharmacological treatment is the first-line treatment for movement disorders for those who respond poorly to the medication or have intolerable side effects caused by medication. Surgical treatment is an alternative, and surgical lesion interventions were the most effective treatment option in patients before the widespread use of levodopa. And lesion therapies of in movement disorders have fallen out of favor with the advent of deep brain stimulation, but now it is they are evaluated and renewed. We expect our intervention to be effective and safe. That means that the motor function of the patients will improve, and respectively the quality of life will improve, and they will not, and the adverse effect will not develop in these patients. The data that were published from first trials are dedicated to the estimation of the efficacy and safety of focused ultrasound treatment the patients with movement disorders showed that this intervention is effective, and the difference is statistically significant between control and sham group, and adverse effects were notably transient. One of the latest research that performed a systematic review dedicated to safety and efficacy of magnetic resonance-guided focused ultrasound neurosurgery for Parkinson's disease, included 11 studies and 80 patients, also showed its efficacy and safety. This systematic review was published in 2021. According to the time of appearance, duration of the clinical symptoms, all adverse effects could be divided into several groups, and the severity of adverse events is predefined as mild, moderate, or severe. And some adverse events are related to different parts of the procedure of focused ultrasound intervention. And according to this systematic review, the procedure-related serious adverse events were very infrequent, and they occurred in 1.6% cases without intracerebral hemorrhages or infections. Adverse events were usually transient and were commonly rated as mild, 79% of all adverse effects, and rarely severe, just 1% of adverse effects. As previously reported, abnormalities in sensation and balance were the commonest thalamotomy-related adverse event. Another important point is targeting. The ventral intermediate nucleus of thalamus is a key relay with the tremor network and has been widely used as a surgical target for the treatment of essential tremor and tremor-dominant variant of Parkinson's disease. However, this nucleus seems to be less relevant to other cardinal symptoms of Parkinson's disease, such as rigidity, bradykinesia, and postural disturbances. Therefore, the most Parkinsonian patients whose symptoms are not just tremor are the surgical Therefore, for most Parkinsonian patients whose symptoms are not just tremor, other surgical targets such as globus pallidus internus and subthalamical nucleus have been tried. We cannot say with certainty which target is better at present. Another very important prognostic factor is skull density ratio, and we still don't know the exact number of sonication at therapeutic temperature. Another significant technical challenge is the targeting of ventral intermediate nucleus of thalamus. Most operators rely on atlas or coordinate-based techniques for indirect beam targeting. Also, these measurements are not patient-specific and can vary in individuals based on cerebral atrophy or other morphological alterations. And the lesion of surrounding white matter tracts, such as medial lemniscus and pyramidal tract within the internal capsule, may be related to the incidence of severity of adverse effects. And this slide shows the potential benefits. This data was taken from the article which was published in 2020. This slide shows the potential benefit of diffusion tensor imaging, which help us to localize both the corticospinal tract and medial lemniscus and demarcate the borders of ventral intermediate nucleus. And here on the slide we can show that after the treatment, the dentarubral cerebral tract disappears. It can't be found anymore. So this was the predictor of good outcome of the treatment. Here's another patient. So all of methods of functional neurosurgical interventions have the advantages and disadvantages, and there are still a lot of questions. such as optimal screening procedure. We still don't know the optimal screening procedure, the optimal prognosis and evaluation of clinical response. We need to develop standardized outcome measurements, and we need to evaluate more carefully neuropsychological and cognitive outcomes before and after the procedure. Here, our own results, our own experience. During the year from 5th of May 2020 to 5th of May 2021, the total number of patients underwent magnetic resonance guided focus ultrasound thalatomy is 34. Parkinson's disease patients are 24 patients, and essential tremor are 10 patients. Total number of therapies is 36 because some patients needed second procedure because of the reoccurrence of tremor. In my presentation, we decided to preliminary analyze information about 27 patients who were enrolled, who were underwent intervention from May 2020 to January 2021. Inclusion criteria are the standard criteria for focus ultrasound intervention, and exclusion criteria were also the standard criteria. The therapy characteristics are: the mean duration of the treatment was 2.5 hours. The mean number of sonication was 14.5, and the mean temperature in the focus of treatment was 58 degrees Celsius. To estimate, to evaluate efficacy and safety, we mark primary outcomes. The primary outcomes are motor functioning. It was motor functioning assessed with the specific scales. The secondary outcomes are the level of anxiety and depression measured with hospital anxiety and depression scale, and the cognitive functioning measured with Montreal Cognitive Assessment Test. The safety was defined as the number of patients with adverse events. Here are the patient's characteristics. The patients from Parkinsonian disease group were older than the patients from the essential tremor group. The duration of the disease was longer in the patient in essential tremor group. Here are the severity of disorders. In Parkinson's disease, the disease severity was measured as with modifying Henn-Yahr scale, and the mean value was 2.5. And in case of essential tremor, it was measured with clinical rating tremor scale, and the median level was 54.5 points. The cognitive status was equal in both groups, and the level of anxiety and depression was equal in both groups. Magnetic resonance guided focus ultrasound thalatomy. The target was ventral intermediate nucleus, was effective in both patients group, and this difference was statistically significant in both group. So, and in the case of patients with Parkinsonian disease, and in case of patients with essential tremor, the motor functioning improved. Here's the profile of adverse effects. All of them were mild and moderate, and they do not last more than 1 month. And just in 2 patients, the instability of gait persisted more than 1 month. Here's adverse effect profile for the patients with essential tremor. Most of the adverse effects were intraprocedural adverse effects, and they wasn't persistent. Here are the results of the patient treatment before and after, the spiral drawing. and remarks. One patient with essential tremor with severe panic attack appeared during the procedure, demanded to stop the procedure, and after just a few sonications, and this patient underwent the procedure later, and he was sedated with benzodiazepines. Two patients with Parkinson's disease showed tremor reappearance in 1-2 months after the procedure, and we still don't know the explanation for this adverse effect. Literature sources explain the immediate adverse effect because of the edema occurrence. These edema surrounds the lesion focus, but there is no explanation for the adverse effects which persist more than several months when the edema disappears. And one patient with a combination of essential tremor and Parkinson's disease underwent thalamiectomy. This patient has the heart pacemaker, which was MR compatible. The limitation of our study: some patients with Parkinson's disease, they have the comparable severity of tremor and rigidity, and after the treatment, we could observe improving motor function according to the tremor reduce. But rigidity and bradykinesia, they didn't change. And also the limitation of our study are heterogeneity and small sample size of our group. I'd like to say thank you very much to my chief physician, Rezida Marat-Mangalimova, and whole my team here in the International Medical Center. And I'd like to say thank you very much to the chief of neurological department, Professor Kutlubayev. Thank you very much for your attention. Thank you very much for your listening.
Dr. Kachimaeva, thank you very much for your presentation. You've been able to gather all our data and present it to our participants. Thank you so much. We are waiting you to the discussion. I know you have a lot of questions to Professor Chang, to Professor Taira, and I think now you have a lot of questions to Dr. Karante according to STN. So let's meet together on discussion session and ask all our questions to them, to the pioneers and more experienced people than we are. And let me introduce our next speaker, Dmitry Krikotin, our radiologist, our eyes, a man who shows us everything inside our patient's brain. So let me introduce and welcome Dr. Krikotin with his presentation about interesting things that he has found during the first year of working as the part of our team. Please welcome.
Dear colleagues, I'm the part of the team in the first center in Russia treatment movement disorders using MRI-guided focused ultrasound. Today I would like to share our experience from the radiologist point of view. It's not easy to be a beginner among the large number of experienced professionals, and especially difficult to be the first in the country. But I think it will work out. Right now we're working with the tremor abdominal form from Parkinson's disease and essential tremor. Next year we're planning to expand targets to start to work with other movement disorders. Patients usually send CT exams by email after enrollment by neurologists. To speed up the processing of information, we train MRI technicians to calculate the SDR. They do an excellent job and save a lot of time for the doctor. The treatment process takes place according to the standard scheme: patient preparation and stereotactics, frame placement, equipment check, align and planning, verify, treatment syndication, MRI lesion assessment. After installing the stereotactics frame, the patient is fixed to the fuse table. Water is pumped to the transducer and equipment retest and planning begins. We use T1 FS PGR for shouldering for two reasons. It allows us to estimate the distance for the cortex spinal tract during treatment, and it takes 4 minutes. So how we have been working on the VIM nucleus. Expansion of the list of goals is planned for the near future. The target on the fused workstation is set automatically depending on the distance of ACP line. If anatomical features are present, manual adjustment is possible. Recalibration and therapeutic series of syndication. Let me show you our treatment. Assessor tremor, 82 years old. During treatment, the effect of the treatment is constantly assessed. The goal of the treatment is to improve the quality of life. This patient set us a difficult task. He wanted to completely remove the tremor in order to return to his hobby, repairing electronics. With the help of pencils, we imitated a soldering iron. Looks good. A couple of tests before and after treatment. The lesion has a very clear structure: necrosis, cytotoxic edema, and vasogenic edema. Vasogenic edema appears with 1 to 2 hours after fuse, reaches a maximum for the 4th or 7th days, and disappears completely by first month after therapy. Cytotoxic edema appears almost immediately after syndication, reaches its maximum size by the 4th or 7th days, and then gradually disappears. By the 3rd month after therapy, the focus of fuse ablation is practically invisible on the usual routine sequences. In this case, the optimal pulse sequences is SWAN or SWI. After 11 months, the lesion can be really defended only on SWAN images. Some centers around the world do not accept patients with SDR less than 0.4. We have the experience treating patients with SDR 0.35 or less. This patient had SDR of 0.35, male, 32 years old, assessor tremor. We reached 51, 52 degrees on multiple syndication. After 6 months, the lesion is visualized only on SWAN. There is no return of tremor. Another case, SDR 0.33, nice, beautiful skull. Woman, 59 years old, Parkinson's disease, reached 57, 60 degrees. Despite the low SDR value, the lesion turned out to be the sufficient size with minimal vasogenic edema. Nice lesion, really nice. Let me remind you, SDR 0.33 Siemens. Another interesting case, SDR 0.34. Woman, 58 years old, Parkinson's disease, frontal hyperestosis. Reached 51-54 degrees on multiple syndication. A small lesion. After 2 hours. Not bad. Next day, another nice lesion. Very interesting case. SDR 0.35, woman, 77 years old, Parkinson's disease, frontotemporal hyperestosis. CT, MRI. Despite the parameters of energy and power, we reach only 47-51 degrees. After syndications, not a trace, not a slightest swelling from syndication. 2 hours after, nothing. Why with the highest SDR? Why with the high SDR and more soft zones on the SDR map, no effect could be achieved? We don't have an exact answer to this question. It's possible to the prevalence of the hyperestosis, the uneven inner cortical plate of the skull more pronouncedly affects the result of a syndication than the value of bone density. Thank you for attention.
Dr. Krikotin, thank you very much for your very interesting presentation. It's been really nice working with you during this year, and we really had very interesting cases with hyperestosis in frontal lobe and frontal bone and temporal bones. And unfortunately, we failed on this treatment, but we tried. And let me introduce our next speaker, and Dipankar Nandi. He is the neurosurgeon, consultant neurosurgeon and head of department, Charing Cross Hospital, St. Mary Hospital, London, and professor of Imperial College, London. Professor Nandi is presenting his work, and he tries to show us more wide application of focused ultrasound in the treatment of patients with movement disorders. And after his presentation, we will follow out to our discussion room, and we have a lot of questions to all our presenters. Please, Professor Nandi, welcome.
So, good afternoon, everyone. It's a real pleasure to be able to join this meeting, and I'm very grateful to Professor Buzayev and Professor Galimova for this kind invitation. In normal times, of course, we would be in a single room and be able to see each other, but this is how it is nowadays. This is somewhere in the middle of the conference day, as I understand it. It's 8 o'clock in the morning in London, but of course it's 11 o'clock in the morning for you. So I would have assumed that the mainstay of the current utilization of transcranial MRI-guided focused ultrasound, it is a mouthful, and hence even the abbreviation is quite long, but we'll just call it MAGFUS going forwards. So I would have thought the main applications of MAGFUS as they exist now, which is thalamotomy for essential tremor, has already been spoken about, and that is really the surgical and procedural detail we can go into. I have been asked to present on what are the possible and current wider applications of this very exciting technology. And hence, it really will be a blue skies kind of presentation. And as I explained to Professor Buzayev and Professor Galimova, that the main interest will probably be the discussions, both with all the participants and also the panelists. So I am a professor of neurosurgery in London, working across these two hospitals, Charing Cross Hospital and St. Mary's Hospital. I specialize in neuro-oncology work and in stereotactic and functional neurosurgery, which of course means a lot of DBS, but also I have been doing radiofrequency brain lesions for over 25 years. This is why MRGFUS is such an exciting technology for me, particularly because it allows us to do these very precise deep brain lesions with literally no invasion at all. So here we go. We know about the thalamotomy for tremor, and that's been now well validated across over a few thousand procedures. We have also done, and of course, other centers across the world have done a fair few pallidotomies, and some even have done subthalamic nucleotomies for Parkinson's disease. So that's an application which currently is getting into the norm. You can also address other involuntary movement disorders. So post-traumatic tremor, some forms of focal dystonia, writer's cramp is just one of them, but you could potentially use this technology to carve a lesion somewhere in the tremor pathway. And that is the other very exciting thing about MAGFUS. You're not restricted to one tract or one entry into the brain, unlike radiofrequency lesioning. You can actually choose to create a whole host of lesions with no worry about the damage to intervening brain parenchyma, and very little risk really of any hemorrhage. So you could think of things like focal dystonia in the cervical spine, cervical region, some forms of camptocormia, so various other movement disorders. Moving on from movement disorders, there are other ailments in the world of neurology and neurosurgery where we have successfully used lesions in the last 50 years, and hence it is very reasonable to consider MAGFUS. Cingulotomy or anterior capsulotomy for intractable pain. There was a center in Italy, which is in Switzerland, sorry, which is currently doing quite a few central thalamic tract lesions for chronic pain, again, based on the experience of RF lesioning. Major depression is being looked at, but not yet in a wider clinical scale. There are reports, isolated case reports of anterior capsulotomy or nucleus accumbens lesions for OCD. Moving on beyond neurological or movement disorders conditions, oncology is a very interesting field. A large proportion of our neurosurgical practice deals with brain tumors, both primary and metastatic. And given the reach of this technology, the fact that we can target something very small in the basal ganglia brainstem areas with no intervening damage, it is something to be considered. There have been a few case reports, isolated case reports, both in animal studies and a couple of human patient case reports about direct lesion cavitation of tumor tissue. Perhaps the more wider studied and more easier to implement is the opening up of the blood-brain barrier. This allows us a transient opening for penetration of various forms of adjuvant treatment. Large molecules of chemotherapy, the most studied, as you will see from the publications, are doxorubicin and probably cisplatin. But this is not something which can restrict to these. Other known oncological agents can be studied. And nowadays, of course, immunotherapy and gene therapy, this can be a portal for the vectors of these treatments to go through to the target area. There have been some laboratory studies mainly looking at liposomes, modified microbubbles, and magnetized nanoparticles to help deliver these agents more efficiently into the tumor bed or suspected tumor deposits. There are a couple of studies, would include animal studies and human studies. At the moment, this is all in the phase 1 stage, looking at safety and viability. It'll take some time to get to the point of looking at efficacy and finally whether they actually deliver better outcomes. Now, one of the studies has looked at the idea of doing repeated BBB disruption. This is an important concept in oncological treatment because it won't be a one-off, and hence it is important to establish that this is safe and feasible. There have been a couple of further studies from the same group. Interestingly, it's also been looked at the pediatric population. Moving away from oncology, we are conscious that intracerebral hemorrhage, the idea of directly treating this sometimes emergency presentation, almost similar to other studies which have looked at lysis of clots using lasers or cavitron aspiration, but using MAGFUS as a means of dealing with deep-seated intracerebral hemorrhage is a possibility. And there is a model, stroke model in a rabbit, which has looked at improving cerebral perfusion using MAGFUS. And finally, which is perhaps the greatest challenge in neurosciences in our day, is looking at dementia disorders, the whole sort of family of cognitive problems, particularly memory problems arising in elderly people. There are studies of direct damage to amyloid plaques. Some of them look at the delivery of the agent, which would be expected to carry out the damage of the plaque. Now, it's a question whether amyloid plaque reduction translates into better cognitive function, but it's one aspect. So, as far as I understand it, now there are about 50 centers which are either treating currently or nearly at the stage of starting treatment. This number, incidentally, when we started using MAGFUS in St. Mary's Hospital nearly 5 years ago now, was 25 or 26. So, in 5 years, that's now 50 centers worldwide. Most of them probably in North America. Several countries in Europe now have centers. And there are a couple in Japan and Korea. To the best of my knowledge, something like 4,000 plus treatments have been delivered. The bulk and the overwhelming bulk has been the standard thalamotomy for essential tremor. But as I mentioned, some pain lesions have been made, some for tremor-dominant Parkinson's. We are part of an international trial for bilateral thalamotomy for Parkinson's, for tremor, and also the unilateral pallidotomy study. And that is, in essence, my presentation. These are the members of our team. Professor Gazroich and Dr. Jones are radiologists. Dr. Bain is the movement disorder neurologist with whom I collaborate strongly and very closely. This is true for all our work, including DBS and RF lesioning. And these are our various researchers and supporting staff. I mean, just like DBS, MAGFUS is a very multidisciplinary team exercise, and that's the way it's going to go in the future, and that's its strength, I believe, which is also true for its neuro-oncological applications. I will conclude now, but as I am told, we will have a session where we can have questions and comments. So thank you very much. I just want to apologize. I just finished, so I can hear myself concluding my own talk. Sorry about that.
Yeah, thank you, Dr. Nandi, for your great speech and telling us about the near future in focused ultrasound and how can we work. And to wider our approaches. And now it's time, it's coffee time. We can all relax, sit, gather together, and discuss all the questions that we already have to each other. So we have several questions, several people waiting in the discussion room. Yes, Professor Nandi, because you are just the only one who has just finished the presentation and you are in our discussion room, I have one question from one of our participants. He's asking how long the effect of treatment do you usually see in your patients? So his question about how many years, months we should announce to our patients when we do treatments for movement disorders using MR-guided focused ultrasound.
So, the other speakers will also confirm, particularly Professor Tyra. So I think what we have found thus far, and we have been doing this for 5 years now in Imperial in London, is the effects are very robust and they are very similar to the old radiofrequency lesions. There's very little difference. And we were all part of this international prospective trial where we did their tremor rating scores at various times. And what we found almost in all cases is what you were left with, the clinical effect at the end of 1 month persisted to the end of 1 year. And some of our cases, since then, we have followed up to 3 years. And there is very little change. The only caveat I would say from my personal experience is at the initial lesioning, it is important to make the lesion as large as possible in all dimensions within the safety profile. Because if you make a lesion which is just enough on table, the tremor will come back.
Thank you very much for your answer. And yeah, Professor Nandi, we have the other question. So there is a lot of question according working on STN to treat Parkinson patients or to work on PTT, telling the truth as the medical side using focused ultrasound. We face the same question. What do we think, what way should we use to treat our Parkinson patients?
I think for standard Parkinson's patients, it is ultimately, even though it presents often as a unilateral disease, most Parkinsonian patients ultimately will be bilateral in their symptomatology and in their presentation. So I would say the bulk of Parkinsonian patients who need surgery, remember the vast majority will never need surgery, medicines will be enough. But those who need surgery, most of them, DBS would probably still be the gold standard because it is adaptable. Parkinson's is a progressive disease and there are non-motor effects as well to think of. Having said that, what we have done is we have done a handful of Parkinsonian patients who are strongly tremorless, elderly, maybe have medical comorbidities. So over the age of 75, I think, especially where tremor is the main problem, especially dominant hand tremor, I think that is where MRG-FUS, I think, is probably my best choice.
Thank you very much. And we have one question from our colleague from Russia, Dr. Neurosurgeon Andrew Sitnikov. He is asking about when our presenters presented subthalamotomy. So his question is, are you talking about subthalamotomy or about lesioning of subthalamic nucleus itself? They are two different targets and they should be clearly explained. So this is his question, Professor Nandi.
Is that a question for the group from Spain?
I think yes, but
I mean, I can only tell you from my RF experience, radio frequency lesions. I've been doing them for 20 years. So yes, we actually make it in the subthalamic nucleus, but we often stack them. So it is not one lesion in the single axial plane, but multiple lesions, some of which go up 0.5, sometimes a millimeter and a half above the subthalamic nuclear plane into the region of the zona incerta. But we do it also for our tremor patients. We don't make a single, not on the ACPC plane alone, but above, at the plane, and sometimes going down, especially with proximal tremor, 3-4 millimeters below the ACPC plane, up to the zona incerta.
Thank you very much. I think our neurologist, Olga Kachumaeva, she's online and in our discussion room. Please, Dr. Kachumaeva, I know that you have a lot of questions to our more experienced colleagues and to Professor Nandi.
Thank you very much. Professor Nandi, may I ask you some questions? Well, if the patient, in case if the patient has the reoccurrence of tremor, what target would you prefer in this case? So if the patient was operated on VIM and the tremor appears again, is appearing again, which target would you prefer?
A couple of questions it would depend upon. One is, how good was the effect the first time round? How much was the control? And also, how long did it last?
The effect was good, quite good at the moment of the operation, and to the close follow-up, it was good. Well, in case of reoccurrence after the 2 or 3 or 4 months after the procedure.
I think in that case, I would simply go and make a bigger lesion in the same place. And what is your target? Do you make it at the ACPC plane VIM like that?
Yes. Mm-hmm.
You could also explore it a bit and try not only repeating the lesion there, but also maybe taking it a couple of millimeters below the ACPC plane, an additional lesion. Because this is the beauty of MRG FUS. With the RF, we have done it in the past, but that involves, you have to make tracts, new tracts in the brain parenchyma. The beauty of our MRG FUS is you're not going through brain, so you can actually almost design your lesion. And that's been our overwhelming experience, that if you make almost supramaximal lesion at the first sitting, the chances of recurrence are small. And because you have the patient in front of you, and we examine the patient, as I'm sure you do, incrementally, you have that safety. When you reach that 50 degrees centigrade, at your thermal MRI, you have this transient effect, so you can check whether there is any capsular effects or any problems with sensations or paresthesia. So it gives you that freedom to really maximize your lesion. But in your particular case, I would just go back to the same place.
Thank you very much. And another question, if it is possible. Well, do you usually use tractography when you targeting some points for the operation, or do you use it just in some cases, or it's a routine process?
So even for DBS, the only time we use routinely tractography is when we are trying to do the PPN. But apart from that, I have not used it routinely, sometimes in research studies. I have a worry about the tractography in looking at the connectomes in tremor, because you're looking at very small structures, and you're looking for the circuit. So, I mean, I'm open to suggestion and open to learning, but so far I feel the best assessment we have is what I work with a neurologist as well, that we work together as a team, and their real-time assessment, and that is why I would place a lot more faith in that, because that is something which is objective, and it's not just a clinical assessment. They also do the spirals and writing. So you can assess both side effects, adverse effects, motor effects, or and the therapeutic effects. So apart from gait, you can assess anything else. So we have always tended to rely heavily. So even our DBSs, we do them awake purely for this reason. But I don't have much experience with tractography in this. We do a lot of tractography for our awake brain tumors, but for this I don't have. So, I'm happy to be educated, but I don't use it.
Thank you very much. Thanks a lot.
Hello, may I ask a question?
Yeah, Professor Chang, welcome back to our discussion room. We have just discussed using tractography during emergency fast treatment. So I have asked previously question to Professor Nandi according to STN and PTT approaches in the case of Parkinson's disease patients. So, and we will be happy to know more about your vision according to this very important and actual question. I know that you prefer to work on PTT, and our colleagues from Spain, they prefer to work on STN. So how do you feel in this situation as the very new medical side? We're quite disappointed thinking about what way we should choose. So my question is STN or PTT?
Yes, I have to say we just have very limited experience in targeting on the PTT. We do not have any surgery about the STN. So maybe I could not give you the answer. But for our experience in the PTT cambotomy, we found that the result really impressed us because the PTT is the connection is a track over all very different pathways. So if you target on the PTT, the axial balancing, the freeze gate, and even the tremor, it improved a lot. But we have very little experience and about how high the temperature should we get, because it's a different anatomy structures. PTT are fibers, it's different from the nucleus. So we also consulted with Professor Tyra. Maybe the temperature should be higher than the usual one we did, and maybe several times of sonication to keep the result. Because in our first 4 or 5 cases, the initial symptoms controlled well, but the symptoms coming back about 1 month or 2 months later. So maybe the temperature is another issue for PTT. For the STN, we did not have any experience for this.
Thank you very much for your answer. Maybe someone else has
May I
a
ask a question, please?
Wow. Good afternoon, good evening, Professor Tyra. We are very happy to meet with you here.
Yes.
Thank you very much for
This is my great
to
pleasure.
the discussion room. Yes.
I have a question for Professor Tyra, if I may.
Yes, please.
So I enjoyed your talk. That was the last thing I saw before I scrubbed up in theater. Now, about the ventralis, the VA nucleus or VO nucleus, do you mean the VOP?
In the atlas of Charlton-Bland, there's a clear distinction between VOP and VOA. But in microanatomical structures, there's no boundary between them. So I usually make in case of RF lesioning, I usually use at least 2 tracks, 3 millimeters apart, and the posterior track goes to the VOP, and anterior track goes VO, slightly anterior and then medial to cover for the VO complex.
That's very helpful. Thank you, Professor Tyra. And you don't have any problems with any capsular effects like face pulling or that with the VOA?
Nothing.
That's very helpful. Thank you.
And may I say something about the thalamotomy or PTT? In my opinion, we shouldn't use the term thalamotomy. because the subthalamic area is very, very wide, covering very anterior to posterior. And so if we make a lesion in the subthalamic nucleus, we should say subthalamic nucleotomy instead of saying subthalamotomy. And if we say subthalamotomy, everything is included. Zona incerta, posterior subthalamic area, pylothalamic tract. So we have to be very precise when we discuss.
Thank you, Professor Tyra. I have a question. According to dystonic patients, you have presented several children you have treated with the MR-guided focused ultrasound. And my question, what is the age limit for children when you start to use the technology?
Okay, at this moment, the patients I showed were with radio frequency lesioning, not with ultrasound. And if the anesthesia is you can readily, the anesthetists are available in the MRI suite with MRI compatible anesthesia equipments, which we usually use intraoperative MRI. I think such treatment can be done under GA, and but the target of VIM or GPI may be dangerous because we have to check the neurological status. In case of pylothalamic tractotomy, it's far away from the internal capsule, and it can be done under GA.
Thank you, Professor Tyra. We have a new member, neurosurgeon from our colleague, a neurosurgeon from Federal Neurosurgical Center, Professor Dr. Andrei Sitnikov. He has asked previously the question. Can you repeat your question, Dr. Sitnikov, please?
Hello, everyone. Thank you, Rizida, for inviting me. And I would like to say hello to all my old friends and colleagues. I wouldn't repeat the question. However, I would like to make some statement. I'm completely agree with Professor Tyra, because we should be really exact with terminology, especially according to new method like focused ultrasound, and we should be completely clear with our targets. If we are talking about lesioning of subthalamic nucleus, we should talk about lesioning of subthalamic nucleus. If we are talking about subnuclear thalamotomy, it's one story. If we are talking about PPT or zona incerta, caudal zona incerta, we should be really clear, because all the possible adverse effects and effects of our treatment are strongly related with our targeting. And I also have a second question. Maybe especially to Professor Tyra, because we had discussed it before. So I would like to ask, why do you think we are still expanding our indication to various movement disorders? Why we don't focus in other targets or in other kind of treatments like radio frequency? So maybe it's a commercial project, because we know all focused ultrasound is quite expensive procedure. So what's a real reason for looking for new indication or new targets?
Okay. This is a very interesting question. I think the incisionless or without any burr is I think our dream. We are neurosurgeons, and our work is to open the skull. But interestingly, the ideal procedure is without the cutting. So most people or most of patients prefer such kind of treatment rather than even if it is a small burr hole. it is invasive they consider. And for me personally, it's easier to do radio frequency and quicker. And of course, it's cheaper for patients, cheaper for more easily accessible. But I think the reason is to minimize the invasiveness. Did I answer your question?
Yeah, I think so, but I still believe the radio frequency or other kind of lesion procedures still have a future, because first of all, some limitations of focused ultrasound, they will ever exist. And the second one, like, one of friend of us told us, a world can afford lesioning. So I still think these two methods will exist in the far future on the same level. But I'm really really happy.
For example, in Japan, the focused ultrasound is only reimbursed just once in life. Okay, so we can't do bilateral procedure. So we still need the RF regioning for contralateral treatment.
Sorry, Takumi, as I understand, you still can perform unilateral focused ultrasound lesion, and second, you can perform radio frequency lesion, and on the other side, right?
Yeah, yes, but bilateral ultrasound procedure is not yet approved in Japan.
It's not approved anywhere.
Yep.
I know that Professor Chang has mentioned to us that he has been having a lot of questions to Professor Tyra. So Professor Chang, please welcome.
Yes, I still would like to thank Professor Tyra to helping us in this unique technique. I here would like to have a question about the dystonia. How do you choose one side PTT, the other side PTT or GPI, or different? How do you select the second target?
Nowadays, we do PTT first because the lesion is smaller, and as I said, it's more media, far away from optic tract or internal capsule, and so can be done under GA. But in case of GPI, it's very close to the internal capsule. Many patients suffer dysarthria or facial weakness and so on. So our practice today is PTT, unilateral PTT first. And if necessary, we wait for at least 1 year to do contralateral GPI. Is that okay?
But why not the PTT in the other side? Using
you mean bilateral?
Yes.
I have no experience of bilateral PTT. Still, I am very scared and I'm afraid of making severe complications.
Okay.
Do you have any experience of bilateral PTT?
Not yet, but the new protocol for Parkinson's disease is staged bilateral PTT. So
yeah, that's right.
Yes. And Professor Tyra, how about the pain control? Do you think the PTT tracheotomy will help the patient to have the pain-free or not?
I have no idea. The PTT has very little to do with the pain pathway itself. So I have no idea. You mean you had the no pain relief after PTT, Tommy?
I have like about 4 or 5 patients, Parkinson's disease. They have the pain relieved after PTT tracheotomy. I think
it is because of relief of the muscle spasm, or no. Many PD patients have spasm pain.
Yes.
Yeah.
Or maybe I think maybe if the edema around the zona incerta, because some very older paper they mentioned about the DBS in the zona incerta might have a pain treatment.
Okay. I'll check.
Okay.
All the papers.
Yes.
Thank you.
Any other questions, colleagues, to Professor Tai Chang? So we have a very unique chance to speak with the most famous people in focused ultrasound field in neurosurgery. My question to Professor Tyra, you've mentioned that first you do PTT to treat dystonia, and then in 1 year you move your target to GPY. Why do we need to wait 1 year? It's something we need to restore. Thank you.
When we do bilateral procedures, for example, the VIM thalamotomy for essential tremor, we usually wait again the one year. But there is no scientific comparison how long is long enough, or there's no comparison between, say, 1 year interval and the 3 months or 2 years, 10 years, and so on. But in my opinion, if a patient had some kind of complications, such as dysarthria or unsteady gait, because of the initial operation, we have to wait. And so if there is no complications, we can do it, say, after 6 months or so. But I am not so bored to do bilateral surgery very early stage.
I see. Thank you very much for answering my question. My next question is according to the approach performing PTT lesion on PTT. So we all know very well how Professor Jean Monod works. And my question is there really we need to do these 6 targets in different points with calculating everything in millimeters, going inferior, superior, back, and putting all these 6 spots in lesioning and working on 52, 54 degrees. So my question, is there any reason to do PTT in the way as Professor Jean Monod does? Thank you.
What we are doing for PTT Tommy is completely different. We make just 1 or 2 lesions covering between the subthalamic nucleus and the VO thalamus. And the John Monod's report says it is effective for tremor too. But in my experience, the tremor doesn't improve very much in case of, say, PTT Tommy. And my impression is effect of GPI lesioning is quite similar to our PTT lesioning. And probably John Monod is making the lesion not only the pallido-thalamic pathway, but also in the cerebellothalamic tract, making a lesion more posteriorly. So So our PTT, probably Dr. Chang, he's making the similar small lesion.
Yes, I just followed Professor Tara's suggestion. And I think I'm still in studying where the PTT is. There are some landmark from the MR. The most important is the MTT, mammothymic tract. You should in the middle of the ACPC plane and about 3 to 4 millimeter lateral to the MTT. Then you can check the response from the patient. I have one patient with severe edema because the lesion is a little bit too low. So we should take care of the lesion below the ACPC plane. That's my comment.
When we have been, thank you very much, Professor Chang and Tyra, asking my question. When we have started to prepare this Congress, we wrote a lot of letters to Professor Jean Monod, asking him to accept our invitation and take part in our Congress too, because we all, I know, have a lot of questions to him, but hope he will see our Congress online and maybe he will accept our invitation next year and we will enjoy discussing with him his approach and your approach on treating patients with Parkinson's disease. So I know that Igor has several questions.
My question is, what borders, what the diseases will be the first who will be treated with MRG fast officially after Parkinson and exertional tremor? So how do you see the development of legal, not scientific, not research, but legal indications on label for this technology?
I think already the effect of, for example, GPI pyridotomy for dystonia is very, very established, and so I think most neurosurgeons will agree with GPI target for dystonia, and but in our experience of GPI for Parkinson's disease, it is sometimes difficult to raise the temperature. So anyway, we need to persuade the government or approval. We need the scientific papers. We already finished, say, 10-case feasibility study for focal hand dystonia targeting the ventral-oral nucleus. And we have a very, very long-term RF lesioning experience. So at least in Japan, I think it's quicker for viothalamotomy or writer's cramp to be approved. But we need probably in every country, we need political movements.
Thank you, Professor Tyra. Just widening Igor's question, my question is about using MRG-FAST and your experience in psychiatric patients, maybe with depression or obsessive compulsive disorders, something new, something exciting, something inspiring us to work forward with our psychiatrists.
You may know that in Japan, the psychiatric indication is very, very difficult because of historical situation, even with deep brain stimulation or RF lesioning. So I think we had better ask Dr. Professor Chang in Seoul, Korea. He is very active bilateral lesioning of internal limb and anterior internal capsule. But we are not very sure that, how big and how large enough lesion we can make with ultrasound in the little bit more anterior and the lateral areas. And in case of scintillotomy for depression, I think it's the target is too peripheral, too far away from the center of the brain, and it is very difficult with the current technique of ultrasound.
Thank you. Yes, we've been talking with Professor Chang from Yonsei University. He promised us to join next year because he has been having vacations and travels with his family. So that's why he has a chance to escape our meeting. And we have one of our participants, very young doctor psychiatrist from Italy. She has sent us a question asking about treating anorexia and obesity. She has checked a lot of literature using emergifast to treat these disorders. So her question is, what can we do to help these patients? Because we have just data from 2018, several scientific research data, and all data is connected with radiofrequency ablation that had been done on 50s and 60s in the last century. So her question is, can we apply the same results from radiofrequency ablation nowadays to treat obesity and anorexia in her patients? Thank you.
I don't have any experience with obesity or anorexia, but in case of anorexia, the bilateral anterior internal capsule is a possible target, but I am not sure. Dr. Chang, do you have any information from China?
From China, as I remember, in China, they have a group with radio frequency. They treated nuclear accumbens for addiction, but it's a big issue for ethic problem. So for mental disease, for me, I'm afraid to touch this field because you never know what the real disease is. Maybe the wrong diagnosis or maybe something wrong. So we need to see if there were more and more big data to see, yes.
Thank you so much for your answers, Dr. Kachumaeva. Any other questions to Professor Chang and Professor Tyra?
Yes, may I ask one more question, please? Well, my question is, if the patient is equally good for DBS and for MRG-FAST, whose decision is the last decision, the patient's decision, the multidisciplinary team, the neurosurgeon decision? Who is the last, whose decision is the most powerful in this?
I think in Japan, the patient's preference is most important. And we explain usually in detail about the possibility of DBS, RF lesioning, and ultrasound. And the majority of patients prefer fast the ultrasound treatment.
So the last point is the patient's decision. So
but in case of, say, in case of akinetic Parkinson's disease, for example, the ST and DBS works fine. So it depends on the patient age. If a patient is not very old, bilateral, very progressive, tremor-free, rigid akinetic Parkinson, I do recommend the DBS. So it depends. It depends on the symptoms and the patient age.
Thank you very much. Thanks a lot.
What about the situation in Taiwan, Professor Chan?
I totally agree with Professor Tara. It depends from patient to patient. If the patient have unilateral symptoms, maybe the FUS is the first choice. And for me, I will recommend patient to receive the focused ultrasound because they have, if the focused ultrasound failure or symptom recurrent or something, they still have chance to receive the DBS. So maybe we just need to, depending on the patient's situation.
Maybe you have patients who had FUS treatment after GBS or GBS after the focused ultrasound. So because our experience is not so big, we cannot have these patients. Maybe you have.
For us, we did not have, but I think Professor Tara ever told me that he have a patient with DBS and removed, and they received the focused ultrasound. Is this right, Professor Tara?
I am not sure, but it is possible.
Yes,
it is possible. The after focused ultrasound, we can do, for example, DBS or radio frequency, but we cannot do FUS after deep brain stimulation as far as the device is inside the body.
The most common question when our patient asks us is tremor and symptom reoccurrence. There is not a lot of data about it. What is your experience in treating patients with focused ultrasound and facing reoccurrence of their clinical symptoms?
Yeah, we usually...
Professor Tara, please.
Okay. We always explain the possibility of recurrence and the possibility of treatment. And I usually say that around 10%, 1 in 10 may have recurrence. And also we always explain the hypotonus, although it is transient, the patient may have hypotonia for several months. This is a very important point, I think.
In Taiwan, the recurrence is about 15 to 20%, I think, because it's a little bit different. If the tremor, you can see the totally stopped during the operation, I think the recurrent rate is low. But sometimes it depends on the targeting or the temperature and the skull density ratio. So if the patient have the tremor relapse, if the degree is not so severe, we just will suggest them to just observe. If the quality of life did bother them, then we will recommend they to have a second operation.
Thank you. We had 2 patients whom we reoperated them. So I would like to invite Marta Narata. I have already, yes, hello Marta, I have already asked your question to Professor Tyra and Professor Chang about treating obesity and anorexia. Yes, if you have heard their answers to you, or do you have anything more to add to your question, please welcome Marta.
Thank you, Resida. I lost the last piece because I was busy. So could you please repeat the question you asked to Professor Tyra, please?
I think you asked about us about the obesity and the anorexia. And actually, I must say I have no experience in this field, but I know it is not just hypothalamic metabolic disorder, but it is a kind of obsessive compulsive nature. And so in case of OCD, we there's a long history of surgical approach to the internal capsule, anterior part of internal capsule. So I think it may work for, I'm not sure for obesity, but for anorexia. And at the bottom of the anterior internal capsule, there is a nucleus accumbens, which is targeted for treatment of anorexia in China, and mainly in Shanghai. And deep brain stimulation is also done. But I am not sure the target is suitable for focused ultrasound because it is a little bit off from the center of the brain.
Yes, I'm interested in this because during my internship to become a psychologist, I'm going to take my state exam to become a certified neuropsychologist in this summer. I'm interested in this because during my thesis, the thesis for my graduation in neuropsychology, I worked with obese people. We did a research using fMRI, and we found that in obese people compared to normal weight people, there is a functional connectivity network that is more active, and it displays nucleus accumbens, left anterior insula, and dorsolateral prefrontal cortex. And we use these seeds to use repetitive transcranial magnetic stimulation, and we addressed these seeds that we found in fMRI. And in fact, we had some improvement in dieting compared to obese people that received the sham treatment. So we did this session of RTMS during 2 months, maybe. And people who received the real treatment, in fact, stick more to their diet and lost more weight compared to sham obese patients. So we found that those areas may be a key and crucial. And I know that dorsolateral prefrontal cortex is a very important, tricky target. So I know that FUSE is more like a lesion, whereas RTMS is neuromodulation. So I know that it's quite different. But I was asking myself if these findings could be an inspiration for using FUSE in these patients, obese or anorexic.
Thank you, Martha, for your comments. We are all so excited about findings you have established during your research work. Please publish and send us, because it's really interesting. And I think that not many people are interested in this field of research and treating patients with obesity and anorexia, but we have a lot of young girls dying due to anorexia, and maybe we will be able to help them in future. Thank you so much. Any other questions on Zoom? And if there is no questions, we can...
I'm so sorry, may I ask one last question?
Sorry.
So
yes,
sorry.
Of course, Dr. Kachimaeva.
It's a great opportunity, and I'm afraid that I'm losing this possibility. Well, Professor Tairo, Professor Cheng, I'd like to know your opinion about the long-existing adverse effects. So if the edema disappeared and the focus of lesioning is quite good and the normal place, normal position with any adverse effects on MRI. So how do you think why it is possible that patients may suffer from gait disturbances or some sensation loss up to maybe 5 or 6 or 7 months after the procedure? Even if the focus is normal, the lesioning is quite small.
Well, the as for the sensory disturbance, some patients may say that the abnormal sensation about the lip or cheek or somewhere around the mouth. And usually it disappears within several months. And I have never seen that such kind of complication induced neuropathic thalamic pain syndrome. And but very, very few patients, 1 in, say, 100, may say, still my taste is strange. And probably this is probably because the border between VIM and VC is not so clear cut. It is intermingled like this. So if we made a VIM here, VC is also covering, not clear cut structure, intermingled. This is the reason why. And in case of, I have never seen the so-called motor weakness or paralysis involving the internal capsule. So, but many patients may say my right side is hypotonic or weak or slow or something. And this is because of the lesion is encroaching too anterior, evolving to the VO nucleus and making the patient hypotonic, and which usually improves within, say, 3 to 6 months. But in case of elderly population, all the patients, it may cause, say, unsteady gait or fall. So we have to be very, very careful.
Thank you very much.
A short comment is about, I think the most important is about the targeting. If you are on the right target, the tumor, I think it may not recur. Usually during the sonication, we see the tumor stopped. Sometimes it's because of the temperature outside the core, the target. If you raise the temperature around 54, the zone 2 maybe have 51 or 52. If the zone 1 is not on the VIM, but the tumor still could be seen diminished. So the strategy of the sonication, I think, is important on targeting.
Thank you very much. Thanks a lot. Thank you very much.
Thank you very much. We all know that it's quite late for Professor Tyra and Professor Chang. And thank you very much for taking part and accepting the invitation. We hope our Congress will become annual event, and finally we will meet together somewhere in the world, and maybe in our UFA, maybe in Tokyo, maybe in Taiwan. I don't know where it will be, but we are very thankful for your participation, for the discussion session, and thank you for sharing your experience. Thank you for being different doctors trying to change the medical care, trying to give patients the opportunity that they deserve. Every patient has a dream to come to a doctor and come back to his family in the evening. Thank you so much for being targets for us, for being people like whom we all want to be. Thank you for sharing your experience so widely and helping us, young medical centers, young doctors, to follow you, to be your students, and to be proud that we know you. Thank you so much. I would like to thank you all participants and tell and ask everybody to share the information about the Congress. So it will be, we record it every speech, and it will be on YouTube and through the Zoom link, and everybody can join meeting afterwards and see and return and find answers to many questions. I'm so happy to be with you today. Thank you so much. Thank you. We will be happy to see both of you in our medical site someday when we will be free of COVID pandemic. Thank you.
Okay, I enjoyed the meeting very, very much. Thank you very much indeed. I hope to see you. Thank you.
Thank you.
Thank you.
After our discussion session, we have a master class. So yesterday we had very nice operation treating patient with tremor dominant form of Parkinson disease. So the master class is more than 1 hour, but I hope that someone will follow and see it. And after this discussion session, we will start translation and everybody can enjoy the results of the operation. Yes, Professor Chang, sorry. Thank you so much. Thank you so much. Take care and see you on the next Congress.
Sí, le queda ahora viendo con detenimiento.
Hello, Dr. Karanta. How are you doing today?
Hello. Sorry. We're still on the focused ultrasound treatment, but we just performed an MRI, so that gave me a little window. But we actually have to get back to it. We are deciding whether to finish or not. My colleague, the neurologist, is inside. How are you? I guess the round of questions is finished, maybe.
Yes, I mean,
I'm sorry.
what type of patient do you have today?
Today we're having essential tremor, VIM lesioning. So it's a 77-year-old patient, and we have just performed the intra-op MRI, and the lesion looks well located, but in my opinion, a little bit small. So I would be maybe happier if, I don't know if you can see it. By the way, we don't have the how to say that? We don't have the antenna inside the membrane as you do. So our intra-HIFU image is not as good as yours, by the way. Yeah, the post-op is fine and the movement detection is very good with Siemens, but we still don't have the internal antenna. And I heard before that maybe your colleague from neurology may have a lot of questions about STN. Is that right?
Yes. We've missed you on our discussion part.
I'm sorry about that.
Yes, a lot of questions according to STN or PTT questions.
Yeah.
Yeah.
Are the other attendees still there so we can get back to the discussion if you want, or yours, because now you were showing a treatment, right?
Yes, unfortunately, we have finished the discussion.
Okay, sorry.
Yes, because it was so late for Professor Tyra and Professor Chang. Yeah.
Okay, hold on 1 minute. I have to.
Sure. Dear colleagues, just a few minutes ago, you've seen Dr. Karanta. He has finishing his second case, emergifast case today. So he missed our discussion part, but he is ready to answer questions about STN approach. And just he asked to wait for 1 minute. He's discussing to prolong the operation, to do the next indication, or just to stop on what he has. Also, the lesion is quite well and good and with very nice borders without edema. And I think clinical result is good, as he explained us too. So waiting for him and preparing questions about STM.
Sure. Yes.
Hello again. Sorry. We're going to do some additional sonication with a little movement towards the tract. So we're moving a little bit anterior, but yeah, I guess I can get some of the previous questions if you guys are still able to do it. I'm sorry, Professor Tyra had to go because yeah, unfortunately in Japan it got too late, I guess. But yeah, if there's some question about STN, I would be happy to answer it.
Yes, the question was about, do you really work on subthalamic nucleus, or should we call it subthalamonucleostomy or STN thalamotomy? So the question was from a neurosurgeon from Moscow.
Yeah, so that's actually a really good question, and we are, now that we are reaching the 20 cases, we have to analyze exactly where the lesions are within the STN or the STN area, because of course you may know the classic concept of subthalamotomy included a lesion within the nucleus, but also a lesion around the nucleus. That was the classic concept of subthalamotomy. Of course, afterwards, with the development of DBS and with more modern imaging, we became more specific and separate within a lesion in the nucleus or a lesion outside, or encroaching the STN, but also the prelemniscal radiation, or the PSA or the caudal zona incerta, even foreal fields may be nearby. We believe, and that's my opinion, that with our third sonication, we are outside of the STN. Hold on, because I'm putting the settings. Axial AP. Voy a hacer una un poquito menos, ¿eh? Sí, menos. So yeah, going back to your question, we actually think that with our third lesion, sometimes we may be affecting a little bit the fibers surrounding the STN, which is actually a sonication that protects us from dyskinesia. And that's from the experience from actually my boss, the chairman of neurosurgery, and also from the previous center where I worked, because they had a lot of experience with radiofrequency lesioning of STN. And that's the reason why, from that question, we would say that it's an STN lesioning, but of course, sometimes it may encroach the area surrounding.
We can just wait when you will finish your procedure, treatment, yeah, and then ask other questions, because I think even myself, I have a lot of questions to you.
Okay, sure. Yeah, we can discuss it in a few minutes.
Yeah, sure. ultrasound treatment. We are going to treat one of our patients with tremor-dominant form of Parkinson's disease. We will show you our teamwork, and it's going to be very interesting and very exciting treatment. MR-guided focused ultrasound is the new and non-invasive treatment for movement disorders. And today you will see how, without touching a patient, without incisions, we can treat his tremor and be quite successful. Let's go and try with us.
Hello, my name is Dmitry Krikotin. I'm a radiologist. Now we started the daily quality assessment to check the equipment.
Hello, my name is Yulia Sidorova. I am a neurologist. Today we are treating the patient with tremor-dominant form of Parkinson's disease. He's 67 years old. He has been having his symptoms from 2016, and now he's on levodopa treatment with very low efficacy.
We have started to prepare our patient for the treatment. Here you can see the standard neurosurgical frame that's going to be placed on patient's head. We use the local anesthesia to the points where we are going to fix the neurosurgical frame. Все. Дыхание нормальное, не больно. Да? See that we have already fixed pins here, standard pins for the neurosurgical frame. And now we will fix the frame to the patient's head. Если вдруг больно, вы нам говорите, хорошо? Не больно? Хотя мы стоим с вами напротив. Иванович, поговорите с нами. Нормально? Справа как дела? Где больше больно? Вот у нас как бы пина стоит прямо посередине этого обезболенного участка, поэтому сложно понять, где болит. Пальцем покажите, где больнее всего справа. Не-не-не, давайте добавим чуть-чуть. Нет, лидокаина добавим, чтобы не больно было. В каком? Сейчас левым. Справа сейчас не болит, да? Так, справа дела.
Если больно, давайте еще чуть-чуть добавим. Все? Меньше теперь? Очень хорошо. So this is the special membrane which helps us to perform the treatment, and it helps to keep the water inside the helmet and protect patient's skin. Владимир Иванович, как дела? Вот. Как у вас дела? Ничего не болит? Да. Before every procedure, we do daily quality assessment to check the focused ultrasound table and the size of the spot. So it's the quality assessment helps us to see that everything is all right with the equipment and works successfully during the treatment. Now you can see our MRI technician Adela, she's performing the daily quality assessment for today. On the MRI machine screen, you can see the phantom here, and Adela is performing the MRI screening for the phantom. And then she will try to do the same treatment sonications as we are going to do with our patient. Встаем, сюда садимся, ногами сюда встаем, поворачиваемся в удобную вам сторону. Да, давайте. Сейчас тихонечко ноги мы поднимаем, Владимир Иванович. И тихонечко вперед чуть-чуть подвиньтесь, немножечко, вот буквально сантиметров 5-6. И ложимся, вот это вот моя рука, тихонечко ложимся, откидываемся назад, голову назад откиньте, еще чуть-чуть пониже, вниз еще чуть-чуть, да, так, нет, еще чуть-чуть, еще чуть-чуть, вот, теперь голову откидываем, все. Что закручено? Что закручено? А?
Ну, это, когда первый раз
Здесь больно у вас?
Да.
Можем добавить немножечко. У нас правая рука, левый талямус. С моей стороны все село. Так, вода пошла? Да. Пошла. Чувствуете? Нормально все? Холодная, да, мы вам говорили. So now we are preparing the patient to the treatment. You can see here that we have fixed him on the focused ultrasound table. And here you can see that water is coming between his membrane and the helmet. Patient's preparation is very important, especially preparation of membrane, and it will allow you to do the operation quicker. So that is why we try to fix everything and do it without mistakes and reduce the float. Так, все у нас здесь. И как только мы МРТ закончим, мы заберем вас с МРТ и будем планироваться. Денис рядом с вами постоит. Как только мы начнем МРТ-лечение, откройте, пожалуйста, на секунду глаза, мы вам дадим вот такую другую сигнальную грушу. Вы на нее нажимаете, если лечение будет невыносимо тяжело переносить. Хорошо? Сейчас мы вам даем грушу, потому что мы проводим МРТ. Как только мы вам эту кнопочку даем, это означает, что мы начали лечение. Давайте сейчас мы посмотрим, как у нас все выглядит до операции. Протяните, пожалуйста, наверх руки, высоко, вот как я вам показываю. Широко раздвиньте, пожалуйста, пальцы. Нет, не руки. Пальцы широко раздвинули и держим руки. Широко держим руки. Давайте с вами посчитаем. От 100 отнимаем 7. От полученной цифры отнимаем 7. Так, скажите, пожалуйста, вашу фамилию, имя, отчество. Скажите, пожалуйста, сегодня какой день недели, дату. Что мы сегодня делаем? Какую? На голову делаем. Работаем на правой стороне или на левой? На правой. So, our analysis are ready? Yes. Do we have agreement? Yes. MRI is ready? Yes. DQA have done? Okay. EKG? Yes. And saturation? Earplugs? Aspirator? Yes. Stocking? Yes. And pumpers? Okay. So we are ready to start. Сейчас мы будем делать МРТ. Вы можете полежать, поспать. Как только мы вас будем выкатывать, это значит практически мы МРТ заканчиваем.
Самая большая разница между первым неврологическим уходом и последним неврологическим терапевтическим уходом. Соединения будут чек-чеки, проверки несколько похожи друг на друга. Самое главное, пока самый выраженный тема, когда его не будет потом. Там очевидно было.
Можно?
Да. Юля, у вас получилось?
О, да.
Ну, все нормально, не переживай.
В госучреждении теперь работаем. Мы такие сквотники. Мы их заставили так и делать. So now we have started our pre-planning stage. We are performing MRI and connecting two machines, MRI machine and focused ultrasound treatment table together. Right now we have placed AC and PC targets. So we're doing planning right now. Поэтому сейчас не пишу ничего делать. Посмотрите, порядок неправильно было.
На точку и на прогрессию.
Спасибо. Дальше пишем. And now we are registering the results of his CT scans with MRI scans that we have done already. It will take less than 1 minute. Адель, давай его вытащим. Пусть с ними тут постоит, он немножечко, помните, беспокоился, что сейчас это все будет. ACPC target. So we have put ACPC target, and then we have chosen the VIM on his left thalamus, and now we just need to move transducer to our target. L25, P9,3, S4,3. Before the treatment, we calculate the skull score. So we can see here that we have 943 elements on. We have 349 skull area, and the skull score is 0.51 Siemens. So these parameters allow us to work and to start the treatment. So now we start with a line stage when we put the lowest energy and the lowest power limit to check the equipment. So time is 13:42 and we do the first sonication. So we put the basic energy level and just we have 42 to 40, so we need to increase the energy level. 3000 ставлю, потому что 42, 40. Сорок три, 41, 47, 44. Хорошо. 47, 44. Сорок три, 42, 49, 46. 49, 46. We have decided to adjust the spot because we have a little bit movement, and then we will redo this sonication again. Now we are moving to verify stage where we should be able to get more than 45 in temperature and check that we are in VIM nucleus and not touching all other important parts of patient's brain. Так, мы пошли на Verify, мы ставим 9000. Александр, чеким его. 55-52, посчитает он нам. So we were able to reach 55 maximum, average 52. And now we are ready to check our patient and see, do we have any differences? Начали работать сейчас. Как у нас дела, Владимир Иванович? Нормально. Нормально. Руку свешиваем вниз. Сильно свешиваем, свешиваем, свешиваем. Так, руку держим. 93 минус 7.
86.
Так, дальше считайте.
По-моему, мы там. 79.
79.
Потому что это дрожало меньше.
Ага. Дальше.
65.
Ага, дальше.
Сейчас.
50.
Угу.
57.
57. Хорошо. Так. Ноги посмотрим пока. Тут, наверное, у нас никаких изменений пока нет.
6,
Дальше.
29.
Ага.
22.
Ага.
15.
Угу. Мы там?
Ну, мне кажется, что в сравнении она меньше, чем...
Меньше стала, да?
Сейчас почувствуйте, пожалуйста. Мои прикосновения одинаково чувствуем? Покусайте губу нижнюю, как вчера. Одинаково чувствуете? 33? Да.
33.
Трактор?
Трактор.
Хорошо. А свое имя? Свое имя? Полностью? А фамилия? Высуньте язык, пожалуйста. Да. Подвигайте языком вправо-влево, вправо-влево. Медленно туда-сюда. Хорошо. Высуньте язык. Я сейчас на него поколю его. Почувствуйте, пожалуйста, правая и левая сторона одинаково чувствуют. Высуньте хорошо язык. Высуньте еще. Одинаково?
Ну да.
Хорошо. Прижмите к себе руку, не давайте мне. Не давайте. Хорошо. Угу. Хорошо. Колечко, как вчера делали. Помните из пальцев? Да. Хорошо. Хорошо. Нет, еще раз возьмите, пожалуйста, с безымянным. А с мизинцем? Вчера тоже не получалось с ним взять из-за тонуса. Попробуйте. Еще раз я посмотрю. Да. Ага. Сейчас все, расслабьте руку. А поделайте, пожалуйста, вот так. Как вчера мы галочку делали пальцами. Вот эти пальцы собирали, а вот эти широко раскрывали. Делаем. Подвигайте, пожалуйста, своей рукой. Посгибайте, вытяните. Какая-то разница чувствуется? Пока так же. Хорошо.
Хорошо, теперь давим как на... Сейчас так.
Хорошо. А теперь
давим
на педаль.
Как на педаль. Хорошо. Угу. Хорошо. Хорошо.
Хорошо. Согните ноги. Согните ноги в коленях.
Согнули в коленях и держим ноги.
Дайте поднять мне их.
Хорошо. У нас тремор меньше же стал, да, Юлия Александровна?
Покой, мне кажется, что да.
Да, покой стал меньше.
Одинаково?
Юлия Александровна вас трогает. Одинаково. Хорошо. Сейчас Аделя вам одинаково? Одинаково трогает, Юлия Александровна? Хорошо.
Проведите, пожалуйста, пяткой с коленки и вниз.
Так. С этой стороны. Хорошо. Сейчас мы, то есть получилось так, что мы понимаем, что мы стоим там, где нам надо. Теперь вам сейчас будем побольше энергию дадим, но сейчас вас обезболим, чтобы вам не было больно. Хорошо?
Знаете, как вы еще с пальцем делаете, я вперед так сижу.
Глазки откройте, пожалуйста. Видите мой палец? Сейчас. Придите, пожалуйста, издалека своим пальцем ко мне. Медленнее. Давайте медленнее еще раз. Хорошо, хорошо. Все, делаем. Так, все хорошо.
Сейчас сделаем кетонол.
So we have checked patient on verify stage, and now we are moving to treatment stage, and we have increased the energy level, power limit, and now we are doing the first treatment sanitation. So during our first sanitation, we were able to reach maximum 60 and average 56. So it's really good treatment. От 100 отнимем 7. От 93 отнимем 7.
86.
От 86 7.
79.
Хорошо. От 79 7.
72.
Хорошо, хорошо. Так. Юлия Александровна вас сейчас посмотрит.
Одинаково чувствуете? Давайте. Давайте. А вот так? Покусайте губу ниже. Одинаково справа-слева? Давайте еще раз. Сейчас наоборот. А покажите мне, пожалуйста, сейчас руку приготовьте, пальчиком покажите, куда я вам сейчас надавлю. Хорошо, язык мне покажите. вправо-влево. Хорошо. Ладно. А на руках чувствительность одинаковая? А вот так. Сожмите крепко. А вот здесь нажимайте. Ага. Хорошо. Раздав. Не давайте мне руку. Крепко держи. Не давайте мне руку крепко. Хорошо. Колечко. Молодец. Нет, подождите, пока еще вот с этим пальцем. Хорошо. Хорошо. Единственное. Давайте попробуем. Хорошо. А сделайте мне, пожалуйста, галочки.
Которые мы делали. Помните?
Да.
Так.
Максимально широко раскрывайте, насколько можете.
А теперь вот так, Владимир Иванович. Прям сильно-сильно раскрываем пальцы, отпускаем. Хорошо. Поработайте рукой сами. Есть какие-то изменения?
Почувствуйте ее, пожалуйста. Мягче не стало? На мой взгляд, стало. Вам кажется, что нет?
Вот смотрите, Владимир Иванович, еще вот так покрутите руку, вот вправо-влево.
На мой взгляд, она стала мягче.
Да, хорошо. Давайте сейчас ноги посмотрим. Тремор у него уменьшился. Теперь нам нужно просто надвинуться чуть-чуть. И в этот раз, слушай, в этот раз вот круглый. Что раз помнишь, как он был, брат?
Еще разок. А наоборот?
Да, тремор сильно значительно уменьшился.
Молодец. Хорошо. Хорошо. Продолжаем дальше лечить, ладно?
Так,
молодец.
Но боль
Не уходит пока еще. Также на 7-8 приблизительно.
Ну, да.
Сейчас еще немножко подождем, пока лекарство подействует, ладно? Если что, добавим сейчас.
We have checked the patient after the first indication. His tremor has improved significantly. Now we are trying to increase the support. We have moved 1 millimeter. Inferior. We have checked the patient. After the first indication, his tremor has improved significantly. So now we are working and doing the next indication to enlarge the support. We have moved to 1 millimeter. Из-за этого наоборот уменьшить максимум скорее, который 57 Да, заходим.
Как дела? Молодец. Сейчас кнопку. Сейчас просто руку положите. 33?
33.
Трактор?
Трактор.
Фамилия, имя, отчество.
Владимир Иванович.
Хорошо, давайте по чувствительности.
Интересно, не поднялась, как температура?
Покусайте губу нижнюю. Одинаково ощущает? Высуньте язык. Подвигайте им туда-сюда. Молодец, хорошо. Высуньте его еще раз, поколю. Высуньте еще. Одинаково? Молодец. Сейчас давайте руки проверим. Вытяните, пожалуйста, их. Посмотрю на них. Разведите пальцы. Ага. Подвигайте сами рукой. Полегче двигать?
Да нормально.
Сожмите мне пальцы. Изо всех сил не жалейте. Ага. Хорошо. Отпустите. Не давайте. Не давайте разогнуть. Крепко держим. Не давайте разогнуть. Хорошо. Хорошо. Колечко. Следующий палец. Молодец. Давайте еще раз безымянным, пожалуйста. Молодец. С мизинцем попробуйте.
У нас по неврологии все хорошо?
Да, да, и он чувствует, что дрожание меньше стало.
Дрожание меньше стало.
Видно?
Как голова?
Нормально.
Нормально?
Ну, совсем, конечно,
Сейчас. Нам с вами сейчас нужно сделать где-то 2-3 еще лечебные, и мы прям закончим. Минут 30 еще работы.
Я хотела показать постуральный есть, то есть у него нет кинетического, есть постуральный и покой. Покой самый сильный, постуральный есть в пальцах. Вытяните руки, пожалуйста.
Широко, широко. Так, руки просто пальцы вот так широко в разные стороны делайте.
Разведите их. Ага. Сейчас.
Все подать. Сейчас в этой же локализации тогда совсем.
Грелки не надо?
Я уйду на лапе.
Там не больше 160. 58-56.
Хорошо. Вытяните руки, продолжайте играть в задачку. Вытяните вторую руку тоже. Разведите пальцы, подержите руки. И продолжайте считать.
106, 114, 122.
Чуть остается, да, у нас постуральный?
Постуральный тот же легкий остался, покой значительно меньше.
Ага.
Сейчас особо.
Я сейчас вернулась на прежнюю позицию, на миллиметр двинулась медиальнее.
Сейчас еще один момент, ладно, 3 секунды сейчас. Проведите мне, пожалуйста, еще раз пяткой. Еще разок. Не, представили меня.
Хорошо. Владимир Иванович, мы скоро заканчиваем. Ладно? Практически все у нас хорошо идет. Мы с вами сделали уже 3 лечебные саникации. Как вы тут руку ощущаете сейчас? Вроде нормально. Голова уменьшилась или усилилась?
Голова в прежнем положении.
Голова в прежнем положении, да? Хорошо. Терпения нету. Чуть-чуть еще. Минут 10 потерпим? Хорошо, договорились. У нас вот просто очень долго, почему мы идем, у нас остывает машина. Вот сейчас мы ждем примерно 400 секунд, только прежде чем у нас все остынет, вся система. Да, поэтому вот так у нас долго. Давайте свесим руку, пусть она там лежит, чтобы мы, если что, заметили дрожание в ней.
Я вижу. Легкая есть. Это, наверное, вообще это похоже на циркуляцию, когда мышцы дрожат.
Ну да.
Вот.
Не замерзли? Проголодались? Нет? Хорошо. Не тошнит нас? Не тошнит. По ощущениям, вот лицо было как-то по-другому, вы сказали. Сейчас как? Хорошо все, да?
Одинаково?
Да, левую руку мы вашу видим.
По ощущениям, учитывая, что правая будет дрожать меньше, будет казаться, что левая как будто больше. Но это не так на самом деле. Это просто потому, что на фоне того, что дрожание правой руки уменьшилось.
Свобода появилась в руке? Да, давайте поработайте ею. Сжимайте, поразжимайте, покрутите ее. Хорошо. Сейчас мы, наверное, сделаем... Вот еще нам где-то 2 лечебные надо сделать, чтобы прям мы были с Юлией Александровной уверены, что все у нас хорошо. Ладно? Вот. Сейчас я посмотрю, сколько времени у нас еще осталось.
У меня в миссии есть диагноз, я ее смотрела. Дневник надо открыть. Дневник открыть. Вот 60, 57. Похоже, так будет 60, 57.
Всегда двойная вилочка ждать.
61, 57.
Сейчас как дела у нас? Сейчас МРТ еще делаем, Владимир Иванович. Посмотрим, как дела у нас. Руки вытягиваем наверх, широко пальцы в разные стороны, держим. 4 минуты. Пальцы широко сделайте, подержите руки. Хорошо. Руки уронили туда-назад. Хорошо? Угу. Владимир Иванович, скажите нам ваш адрес, пожалуйста. Хорошо, посчитайте от 100. 99, 98. Посчитайте снова от 100, отнимаем 7. Мы ноги посмотрим сейчас. Коленом в суставе. Все, держим пока, ладно? Не опускаем. Владимир Иванович, вы на самом деле очень большой молодец. Да. Да, я понимаю вас. Сейчас еще чуть-чуть совсем. Прям совсем чуть-чуть.
Ноги одинаково чувствуют?
Одинаково чувствуют. Одинаково.
Хорошо, пяткой проведите вниз по ноге, пожалуйста. Вот, ну ладно. А наоборот? Ладно. Еще разок. Ну, молодец. Так лучше. Руки чувствуют одинаково? А вот так? Встал.
Хорошо. Встали, да. Все, МРТ быстро делаем, смотрим очаг.
Ага, ладно.
все равно есть 550 секунд. Он маленький. Давайте еще. Я вперед двинулась на миллиметр. Да, можем двинуться. По краю только мы не ходили. Мы можем стать вот по краю. Что будешь делать? Давай еще. Блин, сильно. Сейчас 75. Как дела? Владимир Иванович? Нет, нет, у нас немножечко на МРТ у нас очажочек маленький только. Мы еще хотим 1-2 сделать, Владимир Иванович.
Завтра сделаем.
Завтра не получится.
Подвигайте ногами, пожалуйста, потом. Подвигайте ногами, подвиг. Шевелите руками.
Все хорошо? Ладно. Да, сейчас придется вводить терпеливо. И подержите. Хорошо, хорошо. Можете поднять, Владимир Иванович, если не устала. Как нога? Что? Судороги сводят. Ступней вот так поделайте, вверх-вниз, ступней поделали. Сейчас уже будем все снимать. Все, вот это вот у вас на затылке моя рука теплая. Садимся тихонечко, тихонечко садимся. Ноги не свешиваем, просто садимся, ноги наверху и сидим немножечко, ладно? Как дела? Да. Лучше? Я готова в итоге и пересядем. Готов? Нормально? Хорошо. Садимся. Тихонечко.